To the extraordinary board meeting of Hywel Dda. First of all, my thanks to Carmarthenshire, and also my thanks to a member of the public who identified that we were scheduled to be in Ceredigion. But given that we launched the proposals in Pembrokeshire, it was appropriate that we have this meeting in Carmarthenshire for many reasons. And I'm really grateful to the Council for accommodating us. It was what was quite short notice, so diolch. We've had some apologies, but not many. Jonathan Griffiths, who's Pembs County Council, but he's poorly, and Michael Harty, who is an associate member, but will be joining us tomorrow for the main board meeting, because for those of you who haven't picked up, we have separated our business meeting to tomorrow to deal with this single agenda item today, so that we give it due consideration in light of all of the work that's gone on throughout the summer. And while the work will have focused with the population through the summer, what I have to say is that the clinical staff have been working on how we deliver sustainable services for our population across 3 counties for the last 18 months to 2 years. So rather than us be forced into positions where fragile services close, we have attempted to put some planning in working with the public and coming up with some solutions which you'll hear much more about throughout the course of the morning. There's a few housekeeping arrangements. There is no planned fire evacuation today. By that, supposedly there's no planned fire alarm. So if the alarm sounds, it won't be a test, so we just need to go. Members of the public in the gallery should go down from the gallery in an orderly fashion and follow the appropriate signs, and everybody in the chamber just vacate and assemble behind the castle wall in Knott Square. And there are fire wardens that will check that we're all out. So hopefully that won't occur, and there will be no interruptions to what is a very serious meeting this morning for this board and for our communities. I want to welcome all of the people who took the time to contribute to our debate throughout the summer, particularly those who took the time to come in this morning, but also to remind everybody that we are webcasting. So our audience is quite great across the 3 counties. So for those people who have camped outside hospitals, who have protested outside hospitals and signed petitions, I'm very, very grateful that you have taken the time to engage with us. It may not be what we've all planned for, but what it will give us is a route to sustainability for future generations. If we've caused anxiety, it was not intentional. And I think what we really got to be clear about is what the focus is on healthcare provision right across our communities for the coming year, not for the immediate not for the immediate future. So with that, I have no more to say until we get to the recommendations. And I'm going to hand over the bulk of this morning to Dr. Clare and the real clinical team. This team work on an everyday environment, delivering services for our population. They are the people that are on the front line. They are the people who have told us very categorically over the last 18 months, 2 years, in response to one fragile service or another, that this can't continue. So we are looking to those for some answers. My direction to the board is that we have to make sure today, when we get to the recommendations and the decisions, that you are confident that this is the right direction of travel, that builds a strategy that won't deliver tomorrow or next year, but will deliver, as I've already mentioned, for future generations. So without further ado, Phil, you're on.
Thank you, Chair Dda. Good morning. My name is Dr. Philip Claw. I'm the Medical Director and Director of Clinical Strategy at Hywel Dda University Health Board. So look, this... am I on? Hopefully. Does that help? Can you hear me better? So I'm Dr. Philip Claw. I'm the Medical Director and Director of Clinical Strategy at the Health Board. Today is the culmination of 2 or 3 years' work with our staff and our public. So it's a really important day, and I think the first thing to say is a big thank you to all of our staff, a number of them here today, and also our public for contributing to the outputs that we will describe today. When you look back at the inception of the NHS itself and the welfare state, Bevan and Beveridge could never have predicted the changes to our society. They could never have predicted the ageing population that we have now. But then in the next 20 years, we will see a doubling of the over 65-year-olds. 2 generations ago, people grew up in a pre-antibiotic era. 1 generation ago, people grew up when we only gave aspirin for stroke. Nowadays, treatments have advanced so significantly that we're able to extract clots from people's brains who have strokes at a time of emergency and provide better outcomes. Things have changed so significantly in such a short space of time, but yet our health services haven't adapted at that pace. And they do need to adapt and change to meet the current need, let alone the future need for the next generations. So I think this is a landmark day for health and care services in this area. And it's an opportunity to set a strategic direction and an opportunity to develop services that support people to live much healthier lives, maintain their health and well-being, and also have much better health outcomes and provide clinical excellence to people in this area. Services that are safe, accessible, sustainable and kind. Services that our public can have real confidence in, that are going to provide the highest quality and safety of care, and that attract future generations of staff and trainees to work in this area. Services that we can all be proud of. So with that, I'm going to hand over to Libby Ryan-Davies, our Transformation Director.
Bore da, good morning. My name's Libby Ryan-Davies. I'm the Transformation Director at Hywel Dda University Health Board. In the presentation today, we will set out our responsibilities as a board, the requirements of the Welsh Government guidance on engagement and consultation, and the quality assurance process we've been engaged with the Consultation Institute. We will also remind the board of the work to date of the Transforming Clinical Services programme through Phase 1 and Phase 2, including our approach to the consultation, Our Big NHS Change. Opinion Research Services will present their report on the consultation findings, and Hywel Dda Community Health Council will present on their formal response to the consultation. We will then describe our approach and process to conscientiously consider the consultation findings alongside the work of the programme to date, and how these outputs resonate with the case for change and are translated into a set of clinical recommendations for the board to consider today.
So, what is our responsibility today as a board? I'm Sarah Jennings, the Director of Partnerships and Corporate Services, and it's just to remind the board why we're here today and what we're doing. We have to be satisfied as a board that the process followed to date has been inclusive and been a process of continuous engagement and co-production. Secondly, we need to make sure that we feel that the guidance that Welsh Government has issued in relation to stage 2 of formal consultation has been followed. We have to look at good practice and be assured, is this good practice? And be assured about that and feel confident about that going forward. And we need to show that the process has demonstrated that conscientious consideration of all of the feedback heard, all of the different elements that underpin this, and the many hundreds and thousands of pages of technical evidence, feedback and views and opinions has been balanced and considered. And then our job today is to debate and discuss the recommendations before us and to make decisions. So that's the clarity of what we're here for today. So what is that Welsh Government guidance on engagement and consultation? And I am mindful that the board has looked at this many times over the last 6 months and had various points at which it's gained that assurance. But we are supposed to reflect a change and a shift from to continuous engagement and also formal consultation. There's a place for both. Have we done that rebalancing with a strong emphasis on continuous engagement? The guidance asks us where there is substantial change or an issue requiring consultation, that the NHS uses a two-stage process where we have a really extensive conversation with citizens, staff representatives, stakeholders, professional bodies, a third sector and partner organisations, and then based on that conversation, have a formal consultation on on any fully evaluated or worked up and modelled proposals. So we have done 2 stages. Stage 1 was pre-consultation, and where we engaged formally and developed options, and then stage 2 was formal consultation, which is more of a legal 12-week process. So we believe as a board that this is the right thing to do. It's not just about meeting Welsh Government guidance, which is important, but actually we've always laid out as to we want to really embrace the spirit of what that means to continuously engage. The NHS is owned by every single member of our population, and therefore the conversation and the process of going forward has to be with our whole population. But we wanted assurance from outside to make sure that we completed each of the stages of good practice in this room. So we need to pass through those 6 gateways, and we asked the Consultation Institute to work alongside us, challenge us, make sure we were doing that, and to give us an assurance at the end we had done that. And the board will know we have passed through 5 gateways. The 6th is following today. One is have we scoped it out properly when we've agreed how we're going to do it? The project plan is, have we got a plan that really does deliver on this? The documentation, is it robust? Is it fit for purpose? Is the questionnaire right? Can people understand it? Because this is a very complex service change. And at the midpoint review, to stop and assess whether we're on track and adjust accordingly. And then to conscientiously consider all that we have heard in a way that is genuine and has listened. And then finally, to sign off the process, which is what we're doing today, and confirm that we can go forward with decisions. So those are the gateways we've gone through. We've passed through all 5 and have certificates for all 5 that we are at good practice. The 6th is today, and the decisions.
The Transforming Clinical Services programme was established in April 2017 as a clinically led strategic programme on future health and care, focused on a population health approach in response to local need. The programme itself is organised in 3 distinct phases. Phase 1, which is the discover phase, Phase 2, the design phase, and Phase 3, deliver. And the programme follows the guiding principles established by our clinicians: safe, sustainable, accessible and kind. Phase 1 of the TCS programme, the Discover phase, ran from April to November 2017 and included work on the development of the strategic case for change, engaging with the public through our formal listening and engagement exercise, The Big Conversation, which was undertaken between June and September 2017, and examining models of best practice locally, nationally and internationally to determine emerging models of care for the future delivery.
Bore da, Helen Annandale, Head of Physiotherapy and Carmarthenshire Therapy Lead. As clinical staff, we looked at the case for change. We have long-term strategic issues that need addressing, affecting our clinical and financial sustainability. We examined the case for change with our clinicians, and we found that we have increased demand for many services. People are living longer, which is a good thing, but with long-term conditions. We have many workforce challenges with a number of fragile rotas and over-reliance on temporary staff. Technology is advancing all the time, and some of our facilities are not fit for modern healthcare. As Libby said, throughout the process we were guided that we want our services to be safe, sustainable, accessible and kind for our current and future generations. And we've used these principles throughout phase 1 and 2. At the June Health Board, we launched the 12-week listening and engagement exercise, The Big Conversation. We outlined the case for change in our document, and this was circulated to over 4,000 stakeholders. We also had over 80 different events during the time with staff, public and stakeholders, and we listened to everybody's views.
Good morning, Bore Dda, Zoe Paul-Goff, Head of Nutrition and Dietetics Services and Therapy Lead for Pembrokeshire. So we heard within our population there is a 10-year healthy life expectancy gap between the most and least deprived areas, that we have recruitment and retention challenges of some key staff groups and roles, and although we have shown some significant improvement in some areas of performance, many remain a challenge, for example, unscheduled care. We have real variation in the state of our facilities, and services in remote and rural settings we know are challenging to deliver. There were a number of common themes that we heard were important to people. Quality of care was key. This covered a variety of areas, but in particular, effective communication and timeliness was paramount. Care closer to home and continuity of care were important to most people, as was equitable access to healthcare. With respect to where to receive healthcare, there was widespread support for care in the community rather than in hospital, with particular enthusiasm for hubs or one-stop shops where multiple health and care needs can be addressed under one roof in a local community. Some people told us they would be prepared to travel if it meant they would get quicker access to specialist care. There was significant support for more community services by creating a more flexible, multi-skilled workforce and a willingness to be treated by nurses and non-medical staff for some conditions. Some of the general hospital sites, Glangwili in particular, were considered not fit for purpose. People also highlighted that informal carers are a vital resource and more should be done to support them. On the theme of joined-up services, we heard widespread support for a centralised repository of electronic patient records to allow professionals across a range of disciplines to access notes readily. This was balanced by the need for reassurance that this would be underpinned by secure IT infrastructure with sufficient backup systems.
Bore Dda, my name is Gina Hawkes. I'm Community and Primary Care General Manager for Ceredigion. As has been previously mentioned, part of the first phase of transforming clinical services was looking at emerging models of care. It might be reassuring for our public and our staff to know that these three groups were community care, planned care and urgent and emergency care were led by our frontline clinicians. The community care was chaired by Dr. Sean James. Urgent and emergency care was chaired by Mr. Jeremy Williams, and the planned care was chaired by Mr. Mark Henwood. These groups were informed from the information gleaned from the big conversation. We listened and engaged with engagement with our public. We learned from good practice, not only across the world, but also what's happening locally, and what we must do to comply with legislation. Key to that is the Health Board's current challenges, what we know about current service and performance, and our clinical vision for the future. Thank you.
Phase 2 of the TCS programme, the design phase, commenced in December 2017 and will run until November 2018. And this includes the development of options and proposals for future healthcare, formal consultation on those proposals, and the development of the Health Board's health strategy. The process to develop the proposals that were subject to consultation involved 5 distinct parts. A core clinical group was established to oversee the development of a large range of options, building on the work of Phase 1, including the status quo, and this included 27 options in total during this process. These options were taken through a broad range of challenge and testing sessions with many stakeholders, including our staff, university partners, local authority partners, third sector, and many, many more, including the completion of a SWOT analysis examining the strengths, weaknesses, opportunities and threats to refine the options to a final long list. Underpinning the development of the options was the agreement of a set of modelling assumptions and the completion of initial high-level modelling and costing to inform the options development. A further multi-agency group was established with individuals who had not been involved in the development of the options to develop a set of options criteria against which the options could be considered. The final stage in the process was to score the remaining options against the agreed criteria, and again this was undertaken with a wide range of staff and stakeholders, including ABMU, Health Board, university partners and local authority partners. This resulted in the confirmation of the 3 proposals for consultation.
It's really important. We have a public sector equality duty that we actually understand when we're putting service models and service change in place. What is the impact on people with protected characteristics, with those most vulnerable in our communities? Because many of our services, the people who experience those are the most vulnerable in society. So again, as we've said, it's not just ticking the box for the duty. It's really important to us to try and reach that group of people and understand how any change in services would really be experienced and how it would feel for them. So Section 5 in the closing report covers a lot more detail about this, and there's a huge, we have really put a huge focus on reaching those people through doing equality impacts before we started, what we thought, then testing that, and then doing it again, and then doing it again as we heard more. And of the 145 events we did, 45 of them were with groups who were often where those voices aren't usually heard. They were with seldom heard groups, with people with learning disabilities, with the deaf clubs, with people with sensory impairment, with a whole range of different people who actually came out in force and gave us lots of rich feedback, which was really interesting, not just for the future actually, but for now as well. So this was a dynamic process. It wasn't just 3 equality impact assessments or 4. It was a constant daily discussion. Gosh, how does that impact us? So we've undertaken those, and you can see all of those in your appendices. What did come out is there wasn't anything specific that was particularly discriminatory against any of those groups, but those groups felt the same things as the general public, a worry about transport, access, etc. So they felt those things more acutely, but they actually had the same concerns and weren't disproportionately affected. But we will continue to take that approach and to engage with those groups as we move forward.
Bore da, good morning. Bethan Lewis, Head of Nursing at Glangwili General Hospital. Our family, Tylee Jones, were developed to overcome a potential over-focus on buildings and existing facilities and to refocus on what matters to and the experience of our patients. They were first used at staff and stakeholder events and workshops to test and challenge our emerging options, but have continued to focus throughout our design workshop ever since. The family are broadly representative of the population in terms of health and social issues to reflect our demographics and live in locations that would help test the emerging models. We worked with our Public Health Director to look at prevalence data and to inform our family design. giving them conditions, health and care challenges that are more common in our areas. We as clinical leads have used their experience and our family members to develop scenarios as we have tested our options. We will continue to develop their lives and their needs to show a journey through all our changes as they happen.
The formal consultation commenced on the 19th of April and concluded on the 12th of July this year. The consultation methodologies were designed to be as inclusive as possible in a range of different formats to reach as many people as possible. And this included web resources, regularly updated, frequently asked questions in response to what we were hearing, regular media updates, videos and animation, advertising, social media, and a range of non-digital materials, including leaflets, posters, formal consultation documents in a number of alternative versions, and radio advertising. A particular focus was placed on engaging with staff and seldom heard patient and population voices, meeting people where they felt most comfortable.
Alan Williams, GP and Locality Lead. This is our model for the community, and really it is the foundation for the whole system model, because it's in the community that the vast majority of our patients will be treated. So this model is based on provision of enhanced existing community and primary care, available equally throughout the 24/7. This will be delivered through integrated networks of care, including social care and third sector provision. The model really represents a change of focus from reactive treatment and intervention to more prevention and supporting and informing people to manage their own health and well-being. To do this, we'll be having community staff working in the localities as close as possible to home. We'll be looking really not at treatment or an absence of ill health, more promoting good health and well-being. To do this, we need to adopt a more social model of health, not looking at just health, but also social care, education, housing, leisure. To do this, we'll be using the community assets we have in our localities.
Morning, Jeremy Williams, A&E Consultant, Clinical Director of Unscheduled Care. The proposals for our hospitals, a contentious subject. Quite a large number actually were consulted upon, and these were distilled down to these three proposals, A, B and C. There are some common denominators, the previously described community model, and Bronglice General Hospital continuing to be a secondary care for Mid Wales. Proposal A consists of a planned and urgent care hospital somewhere in the zone between Narberth and St Clair's. There would be two main hospitals, with Withybush and Glangwili Hospital and Prince Philip Hospital becoming community hospitals caring for the needs of the local community. In Proposal B, again, there would be an urgent and planned care hospital in that zone, but in this there would be Prince Philip Hospital continuing as a local general hospital providing an acute medical take, with again Withybush and Glangwili hospitals becoming community hospitals. In Proposal C, again Withybush Hospital would become a community hospital, Glangwili Hospital would be a planned care hospital, Prince Philip Hospital would continue as a local general hospital, and in the zone between Narberth and St Clair's there would be an urgent care hospital. So these have been consulted upon considerably.
As part of the consultation planning and to assist the public in giving their view on the proposals, a number of technical documents were developed and provided through the Health Board's consultation webpage. These included technical documents on population health, demand and capacity modelling, transport including travel modelling, IT and digital, finance, workforce and estates. There was an agreed scope for the consultation which was approved at the board meeting in April of this year to launch the formal consultation. and this included the following matters that had been decided and were not open to influence in the consultation. Those being the delivery of services through a predominantly community model, the separation of planned and unplanned care, the delivery of urgent care at a new urgent care hospital serving the south of the Health Board area, the presence of Bronglais General Hospital in all proposals. However, the consultation welcomed views on how these services could be developed in the future. In the consultation scope, the following matters had not yet been decided and were open to influence in the consultation. We wanted to gather views on whether planned care should be delivered at a new purpose-built site or at a repurposed Glangwili Hospital. Glangwili Hospital should become a planned care hospital or a community hospital. Prince Philip Hospital should be a local general hospital or a community hospital. And the availability of beds at Glangwili and Withybush as community hospitals was associated with the reduction of beds at Amman Valley and South Pembrokeshire hospitals. We also wanted to check whether there was anything else in terms of our models that we hadn't thought about, or whether there were any alternative options to delivering services that we may not have considered. The Health Board commissioned Opinion Research Services, ORS, to undertake an independent analysis of the consultation feedback. I'd now like to introduce Jonathan Lee, the Managing Director of ORS, to present their report.
Bore da, good morning. Bear with me. There we go. That was you. It did work earlier. I was reassured. Go. Don't you love technology? I'm Jonathan Lee. I'm Managing Director of Opinion Research Services, and I'm with my colleague Kelly Locke, Head of Qualitative Research Team, who has managed a lot of the consultation process for this project. And it has been a substantial piece of work. We have received a very large amount of feedback, and I will talk a little bit more about our role in this, but essentially we are here simply to tell you what people have said. We have read the material that has been submitted, all of it, and evidently there are a lot of things that are said a lot of times, and it's important that you take account of the fact that those things are being said a lot of times, but it's also important for you to hear the things that have only been said once, but might be very important to your decision making. As a little bit of background to ORS, we are a spin-out company from Swansea University, and whilst we're based in Swansea, we do work right the way across the UK, across England and Wales in particular, and our work relates very much to social issues, healthcare being one of those, and we do a lot of work on managing statutory consultation. We're based in Swansea, and we've got just over 50 permanent staff. In terms of the proposals, I'm not going to dwell on those. They've already been set out, but information was provided to respondents of the consultation about, firstly, the community services proposals, which obviously form a very important part of this, and also the information on the hospital services. In terms of the consultation process, can we go back a slide? Back up. There we go. I need to be more patient, obviously. Okay. In terms of the consultation, as has already been set out, there is a statutory responsibility to consult whenever you are making significant changes. And more importantly, and most importantly, it is from an accountability perspective. It is for you to give account of the options, the proposals, and for you to then listen, to take concerns into account, and for you to rethink what you may have put out in the first instance in the light of what has been said to you. There may be contrary evidence put forward, there may be arguments there that you need to consider, and it is quite right that you can change your mind. It is not a referendum, though. It's not a numbers game. It is not a popularity contest, or perhaps more rightly an unpopularity contest, where the loudest voices or the greatest numbers should determine the outcomes. It is about the reasons, it is about the rationale, and it is for the Health Board to decide based upon the evidence, all of the evidence. And it's important to recognise that the consultation is a very important part of the input, but it is only one of the inputs that has to be considered as part of this process. Now, with regard to this particular consultation, there has been a lot of consultation undertaken in a lot of different ways, and the methods of each of the strands of that consultation are each fundamentally quite different. And as a consequence, we're not in a position where we can readily combine all of the feedback that we've received to give a single answer. There is different nuances. There are different nuances that come from different parts of the Health Board area. Evidently, the proposals affect people living in different places differently. And therefore, the views on those proposals are inevitably likely to be different in those different places. So we can't simply go and say, well, this is what people think, because people think differently depending on their individual circumstances. And we're not here to develop a formula that reconciles those differences. We're not here to determine what might be best overall. That is for you to decide, but for you to understand how it is that the views do differ in those different places. But the important thing to recognise is that we are not here to tell you the answer. We are here to tell you what people have said. In terms of the consultation elements, there were a large number of responses. We had over 5,000 responses to an open questionnaire. That questionnaire was available online. It was available as a self-completion paper questionnaire. There was an easy-read version of it, and as part of the returns, we also had people who made their own versions of the questionnaire with the answers added to the questions, and they were added into the mix also. These questionnaires are open insofar as anyone can complete them and anyone can participate, and inevitably those people with a view that they want to share will complete that questionnaire. It is not a representative group. It's not what the views of the population as a whole will think, necessarily, but it is the views from those people who want to let you know what they think, and therefore it's important that we take account of that. But alongside that, we have to recognise that people who are perhaps quite complacent about what you're proposing, quite happy, haven't got any concerns, don't feel the need to fill in a questionnaire, we want to make sure that their views are heard as well, that we get a balance. And therefore, we undertook a programme of 17 workshops. Now, they were geographically spread across the area, and a number of workshops were added later on in the programme following that mid-term review, recognising that concerns were particularly strong in some parts of the Health Board area, and we convened additional workshops in those areas. Now, we had 261 people attend, all residents of the Health Board. They were randomly recruited, and that included information being presented to them and feedback being gained from them. And that feedback was both qualitative, in terms of what they thought and why they thought what they thought, and it was also quantitative insofar as we asked them some of those questions that we'd asked in the open questionnaire, so we could understand, well, within this broadly representative group of people, how do their views compare? What do they think of the proposals? We also, as ORS, convened 7 workshops with members of staff. That was 43 staff attended those in total across the 4 main hospital sites. They were split according to seniority, and we talked to a range of different people. Now, that was evidently very limited in its scope, but it was entirely independent insofar as it was with us that they were talking directly. In addition to that, the Health Board themselves, you and your colleagues, convened a phenomenal amount of meetings. You had over 140 meetings, drop-in events, events with staff, events with the particular equalities impact groups, a very substantial number of meetings, and notes of those meetings were taken, and notes of those meetings were then passed to us for us to review and compile a summary of the themes that were coming out of the meetings, and for us to understand how his views differed from the different constituent groups. We received 275 written submissions, so letters, some very straightforward letters, some very weighty letters with a lot of evidence and reports attached to them, from a wide range of different people, from residents, from people living in the area, but also many of the letters came from stakeholders, from organisations that you work with, from representative organisations, from national organisations, and from members of staff who wanted to make sure that their views were heard and that they were able to set out their thoughts, their concerns, their suggestions in a way that they could inform this process. In addition, we took account of what was being said through social media, working with colleagues at the Health Board. We had almost 1,500 posts from Twitter from over 700 individual users. We had nearly 600 Facebook posts that fed into the process. And we received a total of 5 petitions with over 50,000 signatures on those. And again, this isn't a numbers game, but that's 50,000 people who have taken the time to show their concern, and it's important that you take account of that because the decisions that are being taken are important to many people. In terms of the demographics, what we can see in the charts there is that the red bands show us the population of the area, so the residents in the area, split into age groups. The blue bands show us the people that took part. And what we can see is that the greatest response was from people in their 50s and 60s. The blue bands notably higher than the population there, so we had higher proportions from those, it's those, yes, in the 50s and 60s, and also from women. Around about 60% of responses came from women, and that reflected to some extent the fact that a lot of the responses that we had came from members of staff. 40% of respondents said that they experienced a disability that limited their activities at least a little. 1 in 5, 21% of responses came from people who worked from the NHS, and the final group there, carers, who have already been mentioned this morning, 41% of their responses said that they had at least some caring responsibilities. So a very, very substantial proportion, 2 in every 5 of all responses saying that they have at least some caring responsibilities. When we look at the responses by area, again, you can see that there are differences. This is simply the number of responses that we received to the questionnaire from each area. The darker the colours, the more responses that were received. And as you can see, the number of responses that we received relative to the population in parts of Pembrokeshire, in particular those parts of Pembrokeshire towards the coast, was quite high. There was also very substantial levels of response from areas around Llanelli, some areas near Aberystwyth, and also around Lampeter. The numbers in themselves are not the determining factor, but evidently it is helpful for you to see the strength of opinion and the extent to which people felt the need to give you feedback and how that differed in those different areas. So I think that that distribution is quite instructive in that it does identify where it is concerns are greatest and therefore where it is that you need to be certain that the proposals are the best proposals. In terms of the consultation questions, firstly, looking at the need for change, I think it's fair to say that we had widespread support across all of the different consultation elements for a need to change. Across the workshops, over 4/5 of those attended agreed that there was a need to make changes to respond to the challenges. Only 11% disagreed with that. Within the open questionnaire, we looked at different groups of respondents, and within those people who are NHS employees, 3/4 of those completing open questionnaires agreed that there was a need for changes to be made, though 1/5, so 1 in 5, disagreed. In terms of the individual responses, many of them from residents, and I think it's fair to say that we'll come on to the views on the specific proposals, but it's fair to say that many people who completed the questionnaire were dissatisfied about some of the specific proposals. There was still an absolute majority, so more than half, 60%, agreed that there was a need for change to be made. 1 in 3 disagreed, so a substantial minority disagreeing, but a majority of those people, despite not necessarily agreeing with the specific proposals, agreeing that there was a need to do something. There was also a general qualitative support for change, and I think it's fair to say that it was almost universal support across all of the staff discussion groups that we had, that continuing with the status quo was not something that could be sustained. Moving on to the specific proposals then, in terms of community services, the support was there in principle, but if we keep going, I will get the answers. There we go. In terms of the individuals on the open questionnaire responses, opinion was divided. 38% agreed with the proposed locations, 43% disagreed. In terms of employees, 55% agreed, 35% disagreed. And at the workshops, the public workshops, again, opinion was divided, 46% agreeing, 39% disagreeing. Now, within this context, there are a number of things to take away from that feedback. Firstly, this question asked about a lot of proposals, a lot of proposed locations, a lot of specific services at individual locations. Anyone disagreeing with any of those proposals would be disagreeing with the proposals as a whole. So it is important that in going forwards you look at each of the different proposals and establish the extent to which there is support or disagreement with individual proposals, recognising that there are at least some things that at least some people don't like. And I think that it is important to recognise that you've got 35% of NHS employees, that's 1 in 3 of the staff, are disagreeing with something about the community location. So clearly there is work that needs to be done, and it is important to recognise that feedback. In terms of the services provided at each location, so rather than the location but the services, there was even greater disagreement from individuals. 51% disagreed with the services, whilst 26% agreed. Whereas the staff, again, a similar level, 59% agreed with the proposed services, whilst 32% disagreed. Moving on to the distribution of that agreement, again, what you can see is that there's a very clear pattern there, that the areas in red had a majority of those people responding to the questionnaire disagreeing with the proposed locations. The areas in green had a majority agreeing with the proposed locations, and those in yellow, the opinion was divided. There wasn't a majority either for or against. And what we can see is those areas, in particular in Pembrokeshire over towards West Wales, there was consistent disagreement with the proposals, and setting that against the high levels of response that we had in the questionnaire, clearly the proposed community services was a cause for concern, or is a cause for concern for people in those areas. Now, when you look at the other areas, Llanelli in particular, yes, there are some areas there whereby there is disagreement, but the higher levels of concerns, the higher level of questionnaires being returned is not particularly related to the proposed locations, it would appear, because broadly speaking, in many areas surrounding Llanelli, there is agreement there. There are other parts, I think, that recognise in parts of Aberaeron, Ceredigion, Carmarthen, Llanelli, where there is disagreement, but it's very clear that it's Pembrokeshire where there are greatest concerns. In terms of the suggestions that came forward, we received an enormous amount of feedback. We received a very large amount of open-ended text comments, and that has been reported in detail back to the Health Board as part of the report. But just focusing on some of the concerns, there was suggestion that it may be appropriate to consider additional hubs in a number of locations, in particular Milford Haven or Neyland, Fishguard or Goodwick, Crimich, Lampeter and Llandysul were all areas that were mentioned recurrently in both the qualitative feedback and also in the feedback that we had from the questionnaire. There was criticism of the loss of community beds in Amman Valley, need for beds in Cardigan, and there was concern about the number of beds in Prince Philip if it remains a general hospital. Other concerns that came back through the questionnaire were with regard to the realism of the proposals, whether or not it was practical to implement, and also the concern that the community model would be in place before making changes to the hospital services. There was question as to whether or not there be adequate staffing, and it was suggested that it may be appropriate to look at whether piloting was feasible. Moving on to planned and urgent care, there was strong support for separating planned and urgent care. We had 2/3 of residents at the workshops agreeing, 2/3 of employees agreeing, and over half of the respondents to the questionnaire, residents responding to the questionnaire, agreeing that there should be separation of planned and urgent care. But that was caveated in many cases, in particular feedback from staff, that they should be separated on the same site. In terms of the new hospital in the south, in principle, the individual responses, there was strong disagreement. 42% strongly disagreed, 13% tended to disagree, so more than half disagreed. But at the workshops, we had a majority agreeing, and also, in terms of staff, the majority agreed, with almost 1 in 3 staff strongly agreeing with the principle of establishing a new urgent or emergency hospital in the south. In terms of the location, however, there was more division of opinion. In terms of the support for the different area, it was greatest, the highest levels of agreement were in areas between Narberth and St Clair and the surrounding location. There was also support for the proposed location broadly higher in Pembrokeshire than in Carmarthenshire. But there were many people who did not support the proposed location. In terms of the considerations, many of the points raised would be those things that would have been considered, I'm sure: access, road networks, public transport. There were specific concerns, the concern of the extent to which there might be patients diverted to ABMU if the hospital was too far west and people would naturally travel towards Swansea rather than travelling towards West Wales. There were concerns about recruitment. If the location was too isolated, it would be difficult to recruit, and if this was to help improve with recruitment, then that needed to be a key consideration. There was concerns about funding and the existing services in terms of the transitional period. And there were concerns from the north of the area about is the investment in the south going to have a detrimental impact on Bron-Gleis. There were competing arguments on the location, Carmarthen being a more vibrant location, it was argued, with better infrastructure, that it would be the same distance from Llanelli and Haverfordwest, and that there were educational opportunities through Trinity St David's. Pembrokeshire was argued a more appropriate location because of the remoteness of coastal communities already having to travel some distance before even getting to a hospital that may be located in Pembrokeshire. So in terms of the proposals, the support varied across the different consultation elements. It's not that we can go and conclude that there was a clear option that had strongest support. The staff focus groups supported proposal B in the main. They felt that that would meet most needs whilst saving money. And in terms of the drop-in sessions that were hosted with staff, support was clearly divided, but divided between proposal A and proposal B. In terms of the questionnaire, responses from staff, again, proposals A and B with a small majority for proposal B over proposal A, but both proposal A and B being supported by different members of staff. The public preferred proposal A, so proposal A being the two-hospital option over both B and C, and the drop-in sessions that were with the public, again, support was divided between proposals A and B. And then in terms of the individual residents responding to the open questionnaire, greatest support was for proposal B. But it's important to recognise that we did have variations by area, quite clear variations by area. In Ceredigion, support was greatest for proposal A, and then proposal B was seen as the second option. Carmarthenshire had stronger support for proposal B, with proposal C as the second option. And Pembrokeshire, stronger support was for proposal A, but there was substantial support for an alternative option, and the alternative options put forward mainly focused on retaining services at Withybush Hospital. In terms of the distribution there, you can see how it is that views differed. Those areas where there was majority support, so we had more responses, over half supporting option A, coloured in red, option B, coloured in orange, and option C, coloured in green. So you can see that proposal A very strong in Ceredigion, whereas proposal B very strong in particular around Llanelli, followed by proposal C in Carmarthen, and then an alternative option coming out very strongly in parts of Pembrokeshire, despite proposal A coming out strongest overall. And as you can see, the areas to the south-east of Pembrokeshire, the red areas there, bringing that in as the strongest support in that area overall, but clearly it is divided. In terms of the views on the specific proposals, it was recognised that proposal A would maximise resources for community healthcare, and that was seen as a key objective of the proposals overall. There were concerns about removing facilities from an area of greatest population around Llanelli, and the fact that there were needs in that area, and that it could have an impact on Morriston Hospital and possibly on Bron-Gleis Hospital. But it was favoured by the staff, particularly because it was the most radical, it was the most cost-effective, and it placed most emphasis on the community element, which are critical to the success of the whole reconfiguration. It was also suggested that this would be the fairest option, as all three of the existing hospitals would become community hospitals. In terms of Proposal B, it was seen as the main advantages would deliver more services locally within the health board area for as many people as possible. And without services being provided at Prince Philip Hospital, there was concerns about that exodus, as it was so-called described, to the Abertawe Bro Morgannwg University Health Board area. There were some specific concerns about this proposal, though. The uncertainty about where community beds would be provided in Llanelli if Prince Philip was retained as a general hospital, and there were concerns about the fact that there wouldn't be any beds at Amman Valley Hospital under this proposal. Proposal C, on balance, had very limited support, and the main reason for that was the splitting of planned and urgent care across 2 sites, and it was felt that this wasn't viable. Feedback from staff in particular was that it wouldn't be viable both financially and from a staffing perspective. And then in terms of alternatives, more than half of all residents supported another alternative in many areas, and that focused very much on retaining services at Withybush Hospital. There were other comments on the concerns about the exodus to ABMU. Well, shouldn't it be the case that we should look at amalgamating the health boards, which is evidently going beyond the scope of the consultation, but it was feedback that we received, and that's something that evidently would need to be thought about depending on the options moving forwards. But in terms of the 3 proposals, in conclusion, proposals A and B had considerably more support than proposal C. Strong support for another alternative has to be acknowledged across parts of Pembrokeshire. But in summary, I think it's fair that we can conclude from the consultation that both options A and options B command support, especially from staff. It's not the case that either one of those can clearly be said to be a better option based on the feedback received. They both have advantages, they both have disadvantages. And I think it's fair to say that based upon the consultation, it would be reasonable for the Health Board to pursue either of those 2 options, providing that the final decision is informed by all of the information, not only the information coming through from the consultation. But it would not be unreasonable to pursue either option A or option B based upon the feedback that has been received. Thank you.
Okay, many thanks to Jonathan, Kelly and ORS for their presentation. Hywel Dda Community Health Council has a duty as the statutory patient voice. I'd like to invite Sam Denton, Chief Officer of Hywel Dda CHC, to outline the CHC's commentary on the TCS consultation.
Thank you, Libby. Good morning to all. I believe I'm changing slides with the power of a nod, which just shows how the technology is moving ahead. I feel magic. So I'm the Chief Officer of Hywel Dda Community Health Council. We are the statutory independent patient voice body, and really this presentation details our views following the Health Board's public consultation. So a quick word on our role. We have a duty to scrutinise service change. These duties are set out in Welsh Government regs, and there's specific guidance that we and the Health Board must follow on service change. We had a strong role during the consultation, and I think the first question was, what did we do? Well, our members got out there, they listened, we attended all of the drop-in events, we attended a whole range of meetings during the consultation period. We absorbed what was being said as best we could. We looked at a huge range of correspondence, letters, communications, and we will continue to listen. Ultimately, we shared all of these thoughts with the Health Board. So what did we think about the consultation first and foremost? Well, we thought it was generally a good start. There are lessons to learn for further consultation, but overall it began a helpful discussion with the public. Now, we know that this has to be a big strategic consultation at this stage. I think we reflected that it was a lot to ask of the public to take part in this consultation. There was a huge amount of complex detail. Some of the proposals that people wanted hard answers to are still ambiguous. So it was actually quite tough for the public to take part in this consultation, although they certainly did. As ORS have noted, we did see a general agreement that change was needed, but there were lots of concerns too. And I think one of our first messages today is that those concerns must be recognised and respected by the Health Board. So, what next? There's a photo up there of the sun setting over the road, back over the Preseli Hills as I went home from work in the summer. I think I'd either been to a community council or one of the drop-in events, just one of those times where you've got to stop and take a picture. But for me, it highlights that this isn't about the end of a consultation and a decision being made. This is the start of a long journey. We're not going to see overnight changes. We're potentially looking at change over a decade. So our commentary, and we've provided a commentary document, more on that in a bit. Our commentary focuses on key principles at this early stage, rather than speculating too much on the subplots of different service issues. So what are we thinking at this stage? We know people are generally very positive about the NHS services that they use, but too often as a CHC we hear of bad experiences and concerns from the public. Despite the best efforts of staff to manage these, there are big problems in place, and those problems need big solutions. So we feel that system-wide change is crucial. However, despite the need for change, as a CHC, we're not waving all of the proposed changes through. Whilst people like the idea of more community services closer to home, as we've heard from ORS, lots of people are very worried about the proposals. They're worried about accessing or travelling to the services. They're worried about there being enough beds. They're worried they may not be able to be treated quickly enough in an emergency. So bearing all this in mind, what are we concluding? Well, as I've said, we do think there needs to be system-wide changes. But any changes that are made must lead to better, not worse care. We need to see more detail. The public needs to see more detail, and the public needs to have the opportunity to discuss some of these key issues further. A&E, beds, services coming and going from different hospitals. That must mean more engagement, and it may mean more consultation. After this process, as a CHC, we still reserve our right to refer changes to the Health Minister. This is our greatest statutory power on service change, if we still have concerns. We think that there need to be substantial foundations in place for any new system to be built on. You can read more about these in our commentary document, but to highlight a few. Primary care, or more specifically, GP services. These are the main front door for people to access the NHS. But it's a fragile picture at the moment. We need to see investment, we need to see development to get GP services on a solid footing. Community services. We've seen how people are keen to see these, but we need to see that development happen right now. We need to see how it will be safe. The public needs to see what's possible. And as I was reminded by an Assembly member colleague the other day, as an example, we need to see what care can be delivered via the smartphones that many people have in their pocket. We need to see what is possible. Transport. I remember early in the consultation, one lady saying to me, I don't care where the hospitals are. If I can't get there, it's irrelevant. And I think that's a strong message. We need to see the Health Board own the transport challenges that exist in our geography. We need to see innovation. We need to understand how the new system will be staffed. The public know that staffing issues are a big problem for the NHS across the UK. How will the Health Board develop the staffing to make the new system tick? We need to see that. Last year, there was a major consultation on mental health services. A lot of people got involved in that. How will the changes fit with those developing mental health services as they are implemented? That's a key issue. And I think finally, and we've highlighted this separately, early on we need to see how the Health Board will drive this enormous change whilst keeping its eye on the ball for the day-to-day problems that arise. The public need to know that change of this scope won't capsize what we've got now. So bearing in mind what I've said so far, I will stop there. We agree change is vital, but some of the proposals do need more discussion with the public. We expect the Health Board to enable those discussions and listen to the outcome. As a CHC, we'll be there to play our role. And we encourage people to read our commentary document, which is now on our website. Thank you.
Many thanks to Sam for your presentation. In order to develop the recommendations that will be presented by our clinicians today, we undertook a rigorous and robust consideration of the consultation findings alongside the work of the whole programme to date. The principles guiding effective consultation, the Gunning principles, state that the product of consultation must be conscientiously taken into account. We undertook a series of conscientious consideration sessions between the 14th of August and the 17th of September this year, ensuring that all of those who participated read and understood all of the information thoroughly, including that we've heard from ORS and the Phase 1 output report from the first part of the programme. That they conscientiously considered everything that we've heard to enable them to test and challenge robustly. That they reflect on all available evidence from Phase 1 and 2, including the detailed consultation outputs. To review and challenge the consultation proposals particularly, and to consider the recommendations post-consultation that they want to make. 3 sessions were undertaken with a wide group of clinicians across professions, services and localities. And a session was also undertaken with the Regional Partnership Board and the Integrated Programme Delivery Board. We held a consideration session with representatives of all of the local equality groups that had engaged with us during the course of the consultation, and held a very large staff and stakeholder workshop with over 120 participants, supported by the Advisory Board, considering all of the evidence through the eyes of Tylee Jones family members and scenarios that the clinicians had built. The conscientious consideration process was concluded with a clinical recommendations group to agree the collective clinical recommendations for consideration by the Board today. During the course of the consultation, 12 alternative proposals and suggestions were received. An agreed process for considering these alternative proposals and suggestions was developed as part of this conscientious consideration process, and this mirrored the approach taken throughout the options development stage earlier in Phase 2. This involved checking the alternatives against the long list of options previously discounted during the options development process. For those not discounted, a full SWOT analysis of the strengths, weaknesses, opportunities and threats was undertaken by a multi-professional group of clinicians. Those that the clinical group felt should be further considered following the SWOT analysis were to be taken through the same level of modelling as those progressed to consultation, and then proceeded through scoring, full equality impact assessment, and an executive team decision on whether further consultation would be required. This process that was undertaken discounted one of the alternatives when considering against the already discounted options. Therefore, 11 alternatives were progressed through a SWOT analysis by a range of clinicians. From the SWOT analysis, the clinical group did not deem any of the 11 alternatives to be viable new proposals, but agreed strongly that all elements required consideration through the conscientious consideration process.
So, Bore da, good morning. I'm Sean James. I'm a GP from Tregaron and Clinical Director for Primary Care for Ceredigion. So firstly, just some general reflections on the outputs of the conscientious consideration sessions. There was consensus that the ORS analysis report reflected what we'd heard during the consultation and also during Phase 1. Particularly, there was support for more care close to home. There was support for separation of planned and urgent care. There was a need for more joined-up services, but also the impact of travel and access on services, but noting that people are willing to travel for specialist-based care. There was a recognition that we needed more detail in the next phase of our work, but there was also general confusion around the language and terminology that we'd use during consultation, and it needed to be simpler. In particular, the term hub really was something that was poorly understood. Also, we acknowledged the high level of responses from Pembrokeshire in comparison to Ceredigion and large parts of the Carmarthenshire areas. We also noted the petition that we'd received from Pembrokeshire and also the strength of feeling that that indicated. But we also acknowledged there was a tendency amongst residents to over-focus on hospital-based care rather than community-based models of care that we were trying to encourage. Also, the importance of transport and the anxiety around distance to access emergency care. And as somebody who travels across Ceredigion and Hywel Dda, I'm somebody who can acknowledge that one as well. So, moving on to the community model, there was overall support for a community-based approach, but there were areas that needed further development. So there was perceived lack of detail in the proposals, a general misunderstanding of what the term hub or community hospital would include, and that included clinicians as well as members of the public, really. There was a need to move away from buildings and hubs to focus more on networks of care within our social model of health and well-being, focusing on prevention and self-care. There was a need to shift away from community-based beds in buildings to supporting people in their own homes and embracing alternative to community beds. And a need to provide integrated and seamless care in the community, working with our partners in local authority and third sector to deliver a whole system change for our population. We also felt the need to build upon and upscale existing successful projects in our localities that are working in small pockets at the moment. There are good, as a good practice, and we need to ensure consistency of this approach across the health board where that's relevant. So we recognise that our current model in the community is quite fragile. A lot of our people are working on non-permanent contracts, not sure where the funding is coming for next year, so that's one of the issues. And also we felt there was a need for people to see the community model working in practice. We thought about exemplars or early adopter areas where these could be implemented. And we need to demonstrate to the public the concept of this network-based care that we're talking about. Now, the public perception of community hospitals is something we talked about as well, and it's largely based on the traditional model of beds in hospital as opposed to outreach services that can reach out into the community, which is our ambition for these sites. But this needs continuous engagement. We haven't finished our engagement process. We need to continually engage with our public in co-designing these community hospitals and models in our community. So we all committed to an enhanced community model, and this needs to be prioritised and progressed at pace, really, so people can see what the alternatives are to the traditional hospital-based services. We felt if we co-designed and communicated effectively with the public, this will provide confidence and mitigate the impact of where these buildings are going to be located, and allay some of the concerns that have rightly been expressed by members of the public and support us in moving forward.
Dr. Robin Goschel, respiratory physician and hospital director of Prince Philip Hospital. I'm going to talk about the outputs from the hospital model. I think, as we've heard, there was widespread agreement that Proposal C really wasn't a viable option and therefore it was discounted. There was mixed support for Proposals A and B, with there being no clear preference but two clear differences. The key differences are the provision of acute medicine within Prince Philip Hospital and the impact that that will have on flows of patients from the densely populated area of Llanelli to ABMU. But that has to be balanced up with the number of acute hospitals within Hywel Dda and the impact of investment into the community. The agreements were that there should be a separation of scheduled and unscheduled care. However, this should be delivered on a single site in the south, in the new build on the south of the health board, and also that there should be enhancement on the community care, especially in those areas which are more remote within the more rural parts of the health board. There were strong messages throughout the consultation against removal of some community hospital beds, particularly in the Amman Valley area. It's quite a remote area with difficult roads in, difficult roads out, and quite a frail community. There's also recognition that regardless of any of these proposals, there is going to be a flow of patients to ABMU, those specifically around paediatrics and obstetrics, because of the proposed location of the new build urgent and planned care hospital. There's a strength of feeling evident in Pembrokeshire, including a large petition associated with predominantly the removal of A&E from Withybush, and also we need to recognise the ambition of Bronglice Hospital and how does that fit in with the new build and make sure there's clinical pathways which are suitable to taking forward and sustainability of these. And then there was a discussion around the community model and what impact, when it's fully running, fully functioning at 100%, how will that affect the demand within the hospital models? And that actually may make the location of the buildings far less relevant. The key areas of concern raised, which from the ORS report were, and this was frequent throughout all the consultation workshops, etc., were around transport and the infrastructure and the road infrastructure. This was universal across all age groups, but was most prevalent in those who are vulnerable in society. And certainly investment needs to be made into the infrastructure, bearing in mind we are getting increasingly frail individuals in our population. It's necessary to design and develop these through ongoing engagement with our local communities, and especially those areas with the longest travel times. There continues to be concern and over the public's perception about emergency transport, ambulances, and the distances from the acute hubs. Communication needs to be clear communication, understanding the Tylee Jones, the family. What does it mean for the population? If they were a representative of the Tylee Jones, what would their journey be within the proposal that we would recommend? There's also an inherent fear of this is going to happen tomorrow. So whatever the decision has been made after today, is that tomorrow is the start of a new era and change is going to happen straight away. And clearly people have got anxieties around that. But it's an understanding that the transition is a transition, and transition means it will take time, and confidence will be grown in the public in terms of showing that services will be sustainable. And we need to ensure that we reassure the public that these changes will be incremental in nature. That although we've engaged a lot over the last 18 months, and specifically over the last few months in terms of the consultation, the engagement going forward must be continuous, working with the public, staff and partners in terms of the final decisions and design. And there's also the recognition around the workforce and resourcing. Clearly, workforce within West Wales has been difficult, but it's about using people with multiple skills and ensuring that when we are developing the services, we're not destabilising other services, and understanding that the proposals going forward risks destabilisation. There is extensive workforce modelling which needs to happen almost immediately. There needs to be alignment with transforming mental health so that these two programmes run parallel to each other. And in terms of equalities, it just needs to make sure that any patient, any individual within the health board has equity of access, whether that be through transport or actual services provided. Recognition of challenges surrounding Withybush Hospital needs to be recognised. And also it's important as a health board that we continue to work with key stakeholders, partner organisations, and making sure that we make sure that the most disadvantaged members of the community do not remain disadvantaged.
Bore da, I'm Ros Jervis. I'm the Director of Public Health for Hywel Dda. Our discussions and decision-making today must be set in the context of the challenges in the system we seek to overcome in order to provide a system that is safe, sustainable, accessible and kind. The challenges we face in the health and social care sector across Wales are of great public concern, and recent publications, such as A Healthier Wales, our national response to the Parliamentary Review of Health and Social Care, sets out clearly our ambitions to work together to address these challenges. But today, it's important to take a few moments to revisit the picture across Hywel Dda and restate the evidence that underpins our case for change. I'm starting first with some predictions on the impact of population growth and what it's likely to have, not only in terms of the demand on health and social care services, but in the quality of life and health outcomes local people are likely to experience. Put simply, overall our population is growing and is predicted to grow by approximately 20,000 residents over the next 20 years at least. Now, all of which are likely to be of older age, particularly those of 75 years and over. Added to that, the likelihood of having one or more chronic conditions increases with age, and with that the use of hospital and community services. So carrying on as we are is not likely to change the fact that although we are living longer in poorer health. We have a fantastic opportunity today to make decisions that will promote a different way of working together in preventative care across the whole system, which could in turn lay the foundations for sustainable services and create that movement of change we need to do to meet the future needs of generations to come.
We all know how important primary and community care services are. They're the foundation of our health service within this health board. Every year, primary and community care delivers 6 million episodes of care for the population every year. When it works well, we take it for granted. When it struggles and changes, it can generate high levels of public and political anxiety, and it can have a systemic impact on the wholesale health service and cause a destabilisation. So primary care has its challenges. Sustainability, with independent contractors. We've had to manage a rising demand for service delivery, rise in staff costs, and the rising costs of consumables, utilities and locum cover within a flat budget. So costs have increased over the last few years, with us needing to employ locums to deliver a safe service. And the Health Board now directly manages 5 practices within our localities. There are pressures on social care, not least the number of carers in the community to provide social care for our ageing population. The number of care packages that are out there means that people are admitted to hospital because they can't get home care. It means they can't be discharged from hospital because they're waiting for care. So there are people in our hospitals having long stays because there are no care packages available. We rely very heavily on unpaid carers. 1 in 8 people in West Wales, many of them young people, are carers. There's been a study by Carers UK saying the cost of replacing these carers exceeds our annual budget. It's £924 million is the cost of replacing care, unpaid care in West Wales, exceeding our whole budget of £727 million. The provision of unpaid care is getting increasingly common due to our older population, and the demand for this unpaid care is going to increase by spouses, adults and children as the population continues to age.
I should preface this slide by stating that the significant majority of patients who attend the various hospitals in Hywel Dda receive excellent care through the dedication and expertise of staff. However, this snapshot data represents some of the challenges that we face and the difficulties that we face on a daily basis in our systems. If we look at A&E weights initially, you'll be aware that there's a 95% target with regards processing patients through the emergency units. 82.9% was our figure across the various emergency units and minor injury unit in August. We're not on our own in facing these difficulties, but it is of a significant problem. And another important bit of information really is 603 patients in August waited longer than 12 hours in the various units. This is not acceptable. This provides significant problems for these patients. Lots of research which shows that patients do not do well if they stay too long in emergency units. It is a big problem. The length of stay in hospitals for the medical emergency inpatients, 8.4 days on average across the health board, which doesn't really compare favourably with the rest of Wales, and relates to complex discharges and elderly patients with significant problems who can be made medically fit, medically optimised, but there are difficulties in getting them to other places of care or back to their own home. If we look at wait for therapies, a target of 14 weeks was breached on 307 occasions in August. So again, potentially these are acute problems which are made chronic because patients are not receiving the therapy that they require because of difficulties within the various services. Referral to treatment time, so referral from general practitioner to definitive management. We would hope that we would get within a 24-week period for this. Possibly 36 weeks, but 97 to 100 weeks being the longest waits for some orthopaedic patients, again, would not be seen as acceptable. If we look at postponed procedures, these are procedures which can be a significant landmark in a patient's life, something that they work themselves up for. 166 of these procedures were cancelled in the month of July of this year. Within 48 hours of the patient expecting to receive the procedure, usually because there's not an available bed for that patient to be housed in. So these are various significant challenges that we would hope would be addressed by a new model of care.
Good morning, Bore Dda. Andrew Burns, Consultant Surgeon and Withybush Hospital Director. The Health Board faces both current and projected workforce challenges. The figures on the slide very much speak for themselves. We have fragile on-call rotas across the four main hospitals with a reliance on both locum and agency staff to maintain those rotas. And this is despite many innovative recruitment campaigns. Our vacancy rate is approximately 4% across all professional groups. But if we look at general practice, there are high-risk areas in terms of GP vacancies, especially in more rural practices, including a number of single-handed GPs. Approximately a third of our workforce are 51 and over. And if you appreciate that the average retirement age is 62, then over the next 5 to 10 years, we need to seriously consider the impact of the number of people retiring on our future workforce planning.
The health and well-being of our staff is paramount. It is our job to support and enable them to fulfil their current roles and prepare them for future roles and to meet their career aspirations. We need to ensure our staff are supported with flexibility, assurance frameworks and access to education and training. We do believe that 80% of our future workforce already work with us. And wouldn't it be great to keep these within Hywel Dda University Health Board? They will need different skills and competencies to deliver care using new models, focusing on increased proactive care and supported by technology, which will allow them to work differently and to provide safe, effective and quality care. We also need to attract a new workforce, a generation of workforces that use digital technology to enable them to optimise their day and to improve the well-being of patients and clients.
Bore Dda, my name's Paula Evans. I'm the Directorate Nurse for Women and Children's for Hywel Dda. Our estates are old. They range from the 19th century to modern day buildings with a varying degree of functionality, condition and performance. Parts of our main hospital, as I've said, are very old, with some areas built over 60 years old. 51% of our current estate is over 32 years old, and this presents a considerable challenge in terms of running cost, repairs and maintenance, meaning that it costs us more to keep our hospitals open and up to date. We want our facilities to support the provision of modern healthcare and know that some of our current facilities do fall short in areas such as space, a lack of facilities such as ensuite bathrooms and space in general ward areas. And whilst this rarely impacts on the safety of patients or the quality of care received, it often and regularly does impact on the patient experience. So, for example, from a paediatric perspective, we need to look at our parent accommodation within our facilities. We currently don't have parent accommodation, so subsequently parents have to sleep next to the children in the beds. And while this might be acceptable for some parents, some other parents prefer to have their own facilities to actually make sure that they are refreshed to look after their child that following day. We also have a high backlog of maintenance costs, and currently that stands at £61 million for 2016-17. This is split into a high-risk backlog, which is 2.9 million, and significant risk backlog, which is 39.4 million, which are not insignificant sums. Despite the considerable investment of around 136.5 million, which is unimaginable costs, in our estate since 2008-2009, there actually hasn't been a significant reduction in that backlog. And this is largely due to the age and nature of large parts of the estate, and because backlog reduction investments have been targeted on critical service improvements according to the priorities of the Health Board, which is what we would expect.
Bore da, Dalet Simons, Acute Clinical Pharmacy Lead. The opportunity to develop and modernise some of our buildings, our existing sites, is also very limited by the range of constraints, in particular the ability to build or extend any further and the infrastructure required to benefit from digital and technological advances. Any of us who have tried to park outside any of our main sites will know how difficult it is, and that's increasingly difficult for our patients. There's a large backlog of investment required to bring our facilities and networks up to the required standard and support 24/7 services that are digital first and paper light. Our sites are often situated within remote areas, which means the staff members have to be flexible and able to access certain documents and meetings wherever they are. These remain challenges with the understanding, uptake and utilisation of digital systems by both health professionals and the public due to multiple factors, including lack of knowledge, training, system problems, and perceived and real resilience challenges. For example, in our hospitals, observations of patients, for example, their temperature, blood pressure, etc., are collected on paper and put at the end, stored at the bottom of the bed. Also, for our community staff, historically, the majority of informatics investment was focused on our acute sites. And as a result, community staff are poorly served by informatic technologies, which challenges any remote working. In addition, the technical challenges of making our clinical applications work on a mobile platform and suitable mobile coverage has limited the functionality and practicality. In a complex service delivery environment with annual numbers of contacts in the millions, resilience on manual systems creates the potential for significant errors and inefficiencies. However, a significant proportion of medical errors are due to the inadequate availability of patient information and account for significant costs to the NHS each year.
Bore da, my name is Elaine Lawton, I'm the County Director for Pembrokeshire. The challenges that you've just heard about with regard to the future health needs of our population, delivering care currently in our communities and our hospitals, our infrastructure and the workforce is set against our financial position. We have made some good progress this year in stabilising performance. However, as a health board, we remain in targeted intervention, and this needs to be turned around this year. We projected at the start of this year an annual deficit of 62.55 million, and following an allocation from Welsh Government of 27 million, we now need to achieve an end-of-year position of a deficit no greater than 35.5 million. As at month 5, we are 0.9 of a million in excess of our plan, and this demonstrates the further work and further challenge we need to address.
Hello, Bore da. I'm Mary Edmonds. I'm a consultant cardiologist and Glangweedy Hospital Director. Thank you. The following slides summarise the recommendation to Board for consideration. And these recommendations represent the collective view of a wide range of our clinicians. And they reflect many of the things that we've heard about today. We've heard about the many challenges the Health Board face, and these recommendations recognise the need to respond to the case for change. They also reflect the response to what we've heard in public engagement and consultation, which has been summarised and presented to us today by ORS and elaborated on further by the CHC. They reflect also the views expressed by clinicians, staff and stakeholders in conscientious consideration of the consultation feedback sessions, which were described earlier to us by Libby. And they also reflect the debates that were had in September with, again, a wide variety of clinicians and finalised on the 10th of September, which reflect everything that we've spoken about.
I'm really pleased to be able to present to you the first recommendation, and that this recommendation is about the development of our community model. Throughout this process, we have heard repeatedly how important our primary and community services are to our system. They are the bedrock of what we provide. We need to ensure that we create a stable foundation upon which everything else can be built. The model needs to be strengthened with our population in an integrated way with our partners in the local authority, third sector and community groups. We need to shift our focus to look at the long-term well-being of individuals and the resilience in our communities. And we need to grow this at pace, based on what we already know. We have demonstrated a significant range of small-scale initiatives over the last few years, and we now need to implement those equitably across our communities. We recommend that we develop robust, responsive and adaptive networks that meet the needs of our population.
So we request the board commits to stabilising and investing in this community model to build on and scale up local and cluster-led initiatives and services which have already been provided. Over the years, we've had some successful innovations and initiatives in primary care and the clusters, and where appropriate, these need to be resourced, adopted and mainstreamed. We need to identify and develop opportunities for local people to be able to see the model working in practice, with consideration to the areas highlighted in the consultation response as showing gaps in the current provision. The locality services need to be responsive and flexible. We need to be able to co-create, co-produce local solutions for local issues. We need to demonstrate real commitment to the model by resolving current financial uncertainty caused by temporary funding and short or fixed-term contracts. This stifles development and confidence in this model. By not being able to plan ahead financially, we are unable to plan and recruit appropriately.
We want to work with local people to design their own services in their localities to ensure that they're fit for the future generation and beyond. We need to describe clearly what we mean by these integrated networks that we propose in communities and move away from the term hub that we used in the past. We want to enable help and support to be accessed in a variety of ways, both face-to-face and using technology and virtual consultations. We want to commit to concentrating on early co-design of the model in Pembrokeshire, because we've heard so much strength of feeling expressed throughout the consultation about their loss of services in that area. We want to particularly focus on 24/7 community response, which is essential, I think, if community care is to be the bedrock of our new service. We want to commit to a whole system approach to the model where primary and secondary care are not separate, they're not seen in isolation, but they work together to provide the best seamless care for our local people.
Recommendation 2. The Board is requested to approve the development of a plan for the existing community hospitals, working with local communities. This plan will be focused on the provision of ambulatory care, including outpatient services, diagnostics, treatment, observation, rehab and end-of-life care. We need to think of community beds in a different way. Best bed is your own bed, but it might not always be possible for every individual. It's got to be safe. Patient safety is paramount. We need to work with local people to explore the potential for a range of different types of beds within our local communities, whether it be that in hospital, at home or another setting, building around the needs of the person but also the needs of the population. We need to look at developing a commissioning model, which will include the commissioning of beds within the independent and third sector provision, and that also is based on local need and can flex to meet demand. We can also look at and reflect on other good practice that's already happening in some of our counties around this model. We need to develop a transition plan where any change in the provision of current community hospital beds takes place in a phased way and takes into account the development and impact of the proposed model. This recommendation doesn't specify any decision on community hospital beds reduction at this stage, but signals the work to be done with the local communities based on an ambulatory care-focused model.
Recommendation 3. This is the proposal that Proposal C, the separation of planned and unplanned care on separate sites, be discounted. As we've heard, this was not felt to be acceptable by clinicians nor by members of the public.
Recommendation 4. The Board is requested to approve a modification of the remaining proposals for delivering hospital services to include a new urgent and planned care hospital in the south of the Health Board, acute hospital services retained and developed in Brongleis General Hospital, acute medicine retained at Prince Philip Hospital to mitigate against patients travelling across to ABMU and ensuring that we've got greater control of care of our residents, and a repurposed Glangwili General Hospital and Withybush General Hospital offering a range of services to support the social model of health and well-being designed with local people to meet their needs.
In addition, I think it's important that the Board is cognizant of the fact that how important acute medicine is to the daily workload of an acute hospital. And that the plan that has been put forward needs to be rigorously tested and challenged so that it is responsive to the demands over the coming years. And look closely at the patient flows associated with the proposed changes. A transitional plan from the current layout of services with regard to emergency and urgent services at Glangwili and Withybush General Hospitals to the new planned urgent and planned care hospital. This is going to be extremely important to allow safe and sustainable working to continue in the future. Even though it would be very good if we were masters of our own destiny in all areas in Hywel Dda, we have to recognise the importance of our neighbouring health board, ABMU, and that we send certain patients there. And it is very important that our developing health strategy neatly dovetails with ABMU's developing clinical strategy to ensure that effective regional pathways are put in place, again, to maximise patient outcomes.
Bore da, good morning. I'm Julie Jenkins and I'm the Head of Midwifery for Women's and Children, and I'm representing Paediatric Department as well. I think it's fair to say that we have the same issues as all the other services regarding recruitment and retention, and I think a change is definitely needed. I think it's a fantastic opportunity, as Ros said, to align, especially with the public health agenda, the well-being of the families to ensure that babies and children have the best start in life, and that's really important for long-term well-being. However, as a department, we are going to continue and examine a range of options which will ensure that consultant-led obstetrics, midwifery-led care, acute paediatrics and neonatal care are maintained across the Health Board.
Board are Dr. Warren Lloyd, Consultant Psychiatrist, Associate Medical Director and Clinical Director for Mental Health and Learning Disability Services. The Board is requested to reaffirm its commitment and support of the transforming mental health implementation programme and to guarantee complete alignment with the programme requirements, including the co-location of the mental health specialist admission and treatment units at the new urgent and planned care hospital with enhanced and co-designed mental health and wellbeing services in the community.
The Board has also requested to recognise the ongoing importance of Bronglais Hospital in the sustainable delivery of services for the populations of Ceredigion, Powys and South Gwynedd to realise the ambitions of the Mid Wales Joint Health and Social Care Committee. So there is an artist's impression of a bright, shiny new hospital with a single ambulance outside. Certainly whets the appetite. We all look forward to working here. The Board is requested to approve the progression of a proposed new planned and urgent care hospital on a single site through the business case process, which is a 5-case model.
It will also be necessary to undertake a formal feasibility study and options appraisal with regard to the location options within the zone between Narberth and St Clair's. And it's important to also consider the impact the location will have on the surrounding other areas within the Health Board. So it's important to consider the impact on Bronglais, the opportunities that they may provide for the population of Mid Wales. It will be important to work with and develop new models and solutions for enhanced support for those population and communities that are furthest away from the new build. New solutions such as the provision of and location of advanced paramedic practitioners in the community, delivering healthcare locally. But also to consider those pathways for managing emergency conditions which are time sensitive, such as heart attacks and strokes.
In Recommendation 6, the Board is requested to approve the development of a plan to redesign the remaining main hospital sites, working with local people to maximise the range of services and support available aligned to the proposed model, and also to approve the development of a new urgent and planned care hospital on a single site.
In addition to 6, I just want to use an example to illustrate the relevance of this within my own field and position. Last week and the week before, Withybush had an unprecedented demand in terms of emergency admissions, and I think that the senior management team did a very good job in managing those. But working closely with Glangwili, Prince Philip and Welsh Ambulance in coming to a solution for that. And I think that very much emphasised the importance of Recommendation 6, that it illustrates the need why we need to undertake these changes which we've been talking about today. But also, we can't do it alone. We need to work closely with our sort of partners elsewhere within the Health Board, and that includes the local authorities. Third sector, I think we're very fortunate. We have a very rich resource in terms of third sector partners and other agencies. So this will open up opportunities to work closely with other agencies and hopefully develop a plan for the provision of seamless care and support across the hospitals, across the community and other agencies within the Health Board.
Recommendation 7. The board is requested to approve the development of a detailed plan to address the significant concern heard in the consultation regarding access, travel, transport and infrastructure, and ensuring a focus on exploring innovative approaches to accessing care and support. And I'll pass across to my colleague, Rob.
Throughout the consultation process, the public consistently raised concern about transport, infrastructure and WAS's ability to deliver services. Whichever options are finally arrived at will clearly give challenges to WAS, but also great opportunities as we move away from the conventional model of ambulance services to more defined roles within the community, as has been expressed. The golden hour, which came in the early to late 1970s, I, as an ambulance driver at the time, simply picked up patients and took them to hospital. Our paramedics now deliver definitive treatment at the side of a patient. So, for example, on the weekend at a CSRTC, the patient's chest was decompressed. We now thrombolise patients at the side of the road, and telemedicine allows us to take patients further afield. So moving away from the conventional model is very important.
Although we believe that the zone give the best access to the majority of people, it was important to assess and test the suggested alternative locations. We undertook modelling at a more granular level than previously held. We looked particularly at the longest drives to access the emergency care for each location, including our current configuration, and 3 points from the proposed zone: Narberth, St Clears and Whitlands for comparison. The outcome of this exercise was that none of the suggested alternative site locations proved to be the better option than the proposed zone. We also noted that the more granular modelling showed that the outputs of our previous modelling had been overly pessimistic. For example, the more granular modelling shows that 100% of the population are within 1 hour. Average drive time of Narberth, Whitland or St Clears, 3 points within the zone, Brongleis or Morrison hospitals. And certainly from a paediatric and neonatal perspective, as mentioned previously, there are challenges to travel times and suggested location of the site. However, whatever future of Hywel Dda hospitals and the hubs are, they need to be fit for the future and for the next 20 years as an absolute minimum. And they need to ensure that the emerging models of care need to match the population needs of our future generation.
IT is a major enabler of the new model, improving access, efficiency and providing people information and supporting them to manage their own health and well-being. The board is requested to approve the development of a plan to maximise the use of technology as a key enabler to the delivery of the proposed model underpinned by secure IT infrastructure. You can see here the icon is an iPhone. I think that's an aspiration. The current reality is probably a fax machine. The board is also requested to commit to ensuring that digital technology drives information and efficiency and changes the way people can access and engage with services to manage their own health and well-being. A lot of our health board websites aren't up to date. A lot of the information there is inaccurate and hasn't been updated for many years. We can start doing this now and just updating our websites, making sure the information the public have is correct. And this is the biggie, really, developing a fully integrated information system to join up community health, social care, hospital, WAST. Really, there's no excuse for any patient to have a face-to-face consultation with anybody throughout the health board, 24/7, and that person not to be in full possession of up-to-date, accurate information of that patient. When you talk to patients in a hospital setting in casualty, they are shocked that you don't have in front of you in your computer system up-to-date information. We need to make that happen.
Recommendation 9 is surrounding our workforce. We've heard a lot today around why we need to change the fragility within our workforce across all services. We've also heard the request today to ensure that we deliver our existing care and services through into a new model of changed. we request that the board approve the development of a workforce redesign. As clinicians, we feel very strongly that it is essential that we start now. We cannot wait. We need to start to redesign our workforce, the modelling and role redesigns that are required, that we can then take and enable a delivery of sustainable future model. We are talking 10 years, we are talking now, and we all have sleepless nights over the amount of staffing challenges. That's not when we're just on call, but we do really need to do something now and start now for our future workforce.
Our new model will require a new staffing model, as has just been mentioned, including joint roles that span services, regions and organisations. As our population doesn't differentiate between why hospital care, primary care, they move from one to the other seamlessly. Unfortunately, we don't always. Luckily, we've been fortunate to work very closely with our partners in the universities, especially with Swansea University, over the last few months in developing the recommendations that we're giving to you as a board today. But this must continue. Planning and education and training providers, we must start working with them now to account for lead-in times. And the commitment that we've already had from Swansea University has, throughout the programme, and the ongoing engagement will be essential. We must also address the potential impact on recruitment and retention of staff to ensure sustainability both in the short and long term. We must involve our staff in co-design of the future workforce needed to deliver our proposed model. Our organisational development strategy must focus on support the organisation and individuals through transition to the future model. We've already got a number of professions moving their role within the healthcare service. We've got advanced practitioners, we've got the advanced clinical practice in a number of different professions, we've got prescribing across a number of professions that traditionally was the role of doctors. We've got administration being undertaken by different professions, chronic disease clinics, support in A&E. We've got the ideas, we've got the workforce that want to do it. We just need to be supported by the board.
Recommendation 10. The board is requested to reaffirm its commitment to continuously engage and support co-production between all stakeholders, with particular focus on those most vulnerable in our society and those with protective characteristics. This approach should further promote parity of esteem between mental health and physical health, delivering co-designed, integrated and innovative healthcare with improved access to the most effective and safest care and treatment.
Okay, we're nearly there. Recommendation 11 is that the board is requested to approve the further development of all recommendations into the draft health strategy for consideration at the Public Health Board meeting on the 29th of November. So I've been asked to summarise the last 3 hours into 2.5 minutes, which might be difficult. I think, look, I first of all just wanted to thank everybody who's been involved in the presentation, the amount of engagement and the really powerful messages that we've heard from staff who work on the front line in this area every day. I think everyone will recognise that these are really important decisions for our board that we're making, not just for each and everyone who lives in this area now, but also for the future generations to come. We know, I think, that given the challenges we have currently with our services and also with the projected population need in the future that we've heard from Ros, that it's so important that we now do have a strategic direction in this health board, and that's what, of course, we ask the board for today. It's going to be important for retention of our staff. It's going to be really important, though, to excite others to come and work with us here. And trainees as well. So not just staff, we need to be a fantastic training institution. And I suppose, in the end, it must be better for our public. I think that's the key thing. It has to provide much better services, better quality and safety of care. So thank you to our ORS for the detail of the presentation, because I think you've got across the breadth of the view, the complexity of the view from our public and staff, and also the passion from our staff and public. And thank you to Sam from our CHC. I think one of the strong reflections there is that whilst we hopefully will agree a strategic direction at board, actually there's a lot of detail to be worked out. And then there is an enormous opportunity for our staff, not just to work in this new model, but to help us design the detail, and also then for our public and CHC to be with us as we design that detail. And also we will need to work with our partners, not just in terms of developing those service models and delivering them, but also in considering the infrastructure that sits around them, whether it be our road networks or public transport networks like buses and trains. So again, thanks to everybody, and thanks to everybody for listening so carefully. Thank you. Over to Bernie. Oh, actually, I was meant to do one more thing. Apologies. Can I make one more point? So just to remind us on slide 3, just because a bit of time's gone by, of our responsibilities as a health board, if that's okay. So the board must be satisfied that the process to date has remained inclusive through a process of continuous engagement and co-production. It has to meet the guidance as issued by Welsh Government in relation to stage 2 of the consultation process, which is formal consultation. The board must be satisfied that this constitutes good practice through quality assurance by the Consultation Institute, and we need to demonstrate, we need to be satisfied that we've demonstrated conscientious consideration that's been given to all feedback regarding the proposals. Thank you.
Thank you, Phil, and particular thanks to the team who presented. I know it's not your natural environment, and you all did extremely well with passion, sensitivity and humility. I think for us, as a board, we have got, and the other thing I will commend you on is time, because we knew it was going to take a long time to go through the story. You told me 2 hours. We didn't start till 10:10, so well done. I want to spend the next 15 to 20 minutes giving the board members an opportunity to pick up on some of maybe their questions, queries, anxieties, and then we will go through each recommendation one by one, and we will finish by 1:15. So over to board members, really. Delith.
Bore da. I would like assurance, actually, about the involvement and the true involvement of children and young people. From the feedback from ORS and the feedback from members, I find it quite difficult to understand that we haven't had significant involvement of children and young people in the future direction of their services. They are currently our service users, but they're also our future service users and our future workforce. So I'd like to know what plans there are for the future involvement of children and young people, please.
Thank you, Delith. Who's taking that? Sarah?
I'm glad you've asked the question. I think we, through this process, learned a lot about how to actually reach new audiences. One of the things that went really well was we did have a youth video. It was controversial. as the board will remember from previous things. But in terms of the number of shares and likes and comments on it from young people, we reached an audience that I don't think we've ever reached before. I think we've got a long way to go. We're talking with the police about particularly some of the disaffected young people and how we can work with multi-partners who probably have better connections with those groups of people than we do, through our public service board partners, the police, probation service, some of the educational, some of the schools. I think there's a lot more we can do with schools. We did, some of the 45 meetings I referred to that would gone out to the less heard voices did include the youth assemblies, some of the youth groups, a whole range of youth groups. So we did already reach new people, but I think it's given us an appetite and enthusiasm and a knowledge about how we connect with them, which will not be through forums like this or through traditional meetings, but is about going to people and almost, a significant amount on social media and the platforms that young people use, because they do not use particularly Facebook and Twitter, the ones that us oldies use. They have their whole own platforms. That's why you probably didn't see it in some of the feedback from ORS, because the platforms they shared the video on were Instagram, Snapchat and others, which we didn't have a listening tool for. So I think we've learned a lot and we will do far more. And they are far more challenging than many others in terms, I know the Chair and Chief have sat in front of them before. The questions they had are much more probing. And you're right, it is the generation that comes that these services are going to be for, so we have to listen.
Thank you, Chair. The aspiration of the Health Board to create an entirely new community model, a greater resilience, seamless care and so forth, well, those are also aspirations shared by our 3 local authorities. And I was heartened to hear the local authorities called out as key partners on a number of occasions in terms of encouraging early intervention, prevention, getting people out of hospital quicker. So we need to work with our local authorities even more intensely than perhaps we've done in the past. Across the 3 local authorities, there's a great deal of good work being done, sometimes in a different way and a different pace, and so we need to absolutely prioritise our links with local authorities. There's also links in with Recommendation 8. We need to create the architecture, the interface and the shared standards in order for health and social care to talk effectively together, to release time for professionals to actually do the caring and the working with patients and service users. So it's a really good sort of aspiration which is fully shared, I'm sure, by local authorities.
Thank you, Chair. I'd just like to draw attention to one element of feedback which didn't really make it through to the presentation, but is referenced in the main supporting document, the SBAR. And it's on page 16 of the SBAR, and it's headed Meeting the Challenges. And there's a statement there that there were very low levels of agreement that any of the proposals would successfully meet the challenges. So that's any proposal. So irrespective of what we agree today, I'm looking for some reassurance that we have a plan in place that we are going to address to make sure that whatever we agree will start to address the challenges, otherwise it's not worthwhile. But secondly, what we're going to do then in terms of trying to turn around that public perception and convince the public that it is worthwhile, it is going to address the challenges, it will lead to a better set of services in the future.
I'm handing that to the Chief.
Yeah, thank you, David. And I think it is a really important thing to reflect on, picking that out. I think it was the right thing to pick out, because actually what we heard through the whole of the summer in all of the various events was the level of concern about have we got this right. That's quite a difficult, challenging, balancing act, because actually what we do know, and I think that we've heard it this morning, is what we've got at the moment is becoming more and more difficult to continue to deliver. And what we heard very clearly, I think, particularly from our clinical staff, was the proposals that were put in place gave us the best chance of doing better than we currently do and addressing some of those challenges. However, we do need to recognise that it's very difficult to give guarantees in that environment, that we do need to continue to work with our clinicians, but also with wider partners and at a national level about some of the challenges, particularly around workforce, because we need to ensure that what we have in place will be better.
I think the discussion going forward and the commitment I think that we've heard today through a number of the recommendations is that we have to continue to talk about those things both with our staff and the public. But I think what I've heard loud and clear for probably the last year or so is that the proposal that we put together, and indeed the recommendations now reflected here, give us the very best chance. I don't think we can give firm guarantees, but we have to make sure we're doing our best and moving things forward in the best way that we can as an organisation.
Thank you. Thank you, Chair. I think what has been affirmed and reaffirmed throughout this whole process is the important relationship that public and patients have in terms of their primary care services and the relationship at that very local level with practitioners in their own communities. I think what I'm really encouraged by throughout this process is the absolute engagement of all clinicians, of professionals, members of the public, in terms of that being the direction going forward. And so what I would really be seeking now, we've heard that there are pockets of good practice, but we've also heard the significant fragility within our system. And whilst we're addressing those, and that is in the line of direction of our travel, and also in line with the national model for primary care, what I will certainly be seeking as the Director for Primary Community and Long-Term Care Services is now the investment and the opportunity to develop this in the short term whilst we move towards the new hospital model for the future. But building on our community and primary care services is going to be key to that successful model in the outcome. Thank you.
Questions, if that's possible. So firstly, in relation to workforce education, recruitment and training. That's certainly a key theme that we've picked up in terms of the consultation, and certainly one of the recommendations from the CHC. And it's nationally recognised that our current NHS is not fit for purpose in training our practitioners. It tends to be secondary care focused and not in primary or community care, and furthermore it tends to be in an urban context as opposed to a rural context. And that's not sustainable for Hywel Dda. So my question is how will either of these TCS options support the training of a sustainable, skilled workforce for the future, particularly for our rural communities, and certainly for our ambition, which is care closer to home. And the second point is in relation to my role as Chair of Quality and Safety. Quality and safety is the #1 priority for us as a board. And we recognise that there is anxiety amongst the public. Certainly there is an appetite for change amongst the public, but we've got to recognise that during this transition period, we have to make sure that our services are safe and that they are sustainable. And therefore, I'm seeking assurance as to what strategies and plans we've got in place to ensure that during a transition period, safety and quality of our services continue to be of paramount importance, and that we clearly demonstrate that to our public.
Yeah. For each element of the model, we need to ensure that we have a workforce that is fit for the future. We need to establish what roles are required and work with our universities and local education providers to ensure that's delivered. It is critical as well that we don't just think of the workforce as the health workforce. It also includes our carers and our volunteers and employees of other sectors. We will continue, as we have already begun, to develop our Grow Your Own strategy, which is our career pathway strategy, which will look at some of those educational arrangements in local communities. And we will look to develop new and innovative roles that will span the services, the regions and those organisations. We're going to work with our education providers to ensure that rural health educational experiences are seen as important as those secondary care experiences. And we have already begun to have conversations with Health Education and Improvement Wales, which become a body within the NHS in Wales as of Monday. So we will be very much looking at how we provide those training opportunities in our rural settings. In addition to that, with our university partners, we are also looking at what alternative arrangements to training there are available to make sure that we can deliver those educational requirements as local as possible to our workforce. rather than as at present where employees have to go or individuals have to go away to undertake their training. And secondly then, in terms of our organisation, as we've said earlier in the presentation, 80% of the workforce today will be our workforce of tomorrow. So part of the whole workforce and OD strategy will be how we work with our staff, engage and involve our staff now in terms of what those roles will be and how they will contribute towards the development of those roles. And the OD strategy will provide the support for individuals through transition.
But even with all of that, Lisa, if we don't get the service models right, we won't recruit. And I think that's what's been peppered through the whole of this morning's presentation. So unless people come to an organisation that's responsive and receptive to today's health service, we just won't recruit.
Absolutely.
Mandy.
Okay, so my answer probably won't be quite as succinct as Lisa's, but certainly I think I would want to draw the board and others' attention to the quality improvement framework that we as a board approved earlier this year, which set out very clearly 5 key priorities. And for me, whilst we've heard that safe, sustainable, accessible and kind services must be our key strapline, there are 5 key priorities that we as a board have signed up to. So going forward, as part of the transition journey and ultimately the services that we're providing, I would say that we need to hold fast to those priorities. And just for ease of reference, that's looking at no avoidable deaths, looking at how we protect our patients from avoidable harm from the care that we are providing, reducing duplication and eliminating waste, reducing unwarranted variation, and we've heard quite a bit about the need for the new service, new models of care to actually take us in that direction, as well as increasing reliability. And also, and perhaps most importantly for me, is the focus that we've given within our quality priorities on what matters to patients, service users, their families, carers, and of course our staff. Now, that's a lot of words, but actually behind that, there's a lot of work going on to make sure that we've got the key enablers to help us measure and assure ourselves that the services we provide going forward are going to be safe and of high quality. And some of that is in the development of our quality and safety dashboard, which we will be receiving in October. That is an iterative process, so as our services change and transform, so will the quality metrics and the indicators that help us understand where something perhaps is going off course, and we need to take early action in response to those indicators. The other thing as well, and I didn't come in when Delith asked the question, but about patient experience, that's one of the key pillars that we need to be thinking about. So using the feedback, both real-time and retrospective, from our patients, our service users, their families and carers, not just adults, but young people as well, to actually help inform whether in fact the service does feel safe and is of the quality that they were expecting. And if not, through publishing results of our quality measures, making sure it's very clear to the public and our patients what the current position is and, importantly, what we're doing about it.
You wanted to come in on this?
Yeah, thank you, Chair. Just on both points, actually. I mean, on the first point, I mean, everything that Lisa said, absolutely is going to be at the heart of this. In the end, our workforce is the thing that enables us to deliver. So it's got to be at the centre of this. I would say, just at a slightly higher level, having a strategy, because of the nature of the long-term nature of having training in place, the lead times that we have on training, having a strategy and a real sense of where we're going as an organisation means that we can plan possibly in the most comprehensive way that we've never done before for the workforce for the future, rather than maybe what we've seen in the past. And I know you've seen some of this, John, about maybe just having a few roles being developed here and there. So I think the first step of knowing where we're going means that Lisa and the teams can start to think really carefully now about what that means for the kind of staff we're going to need in many years' time, and we can start to deliver that now, as well as some of the more short-term things. I guess the other part of that for me is we've looked at across the world, as we saw some of that today, everything that people are doing in this area. I'm not sure we've seen anywhere any organisation, maybe perhaps globally, trying to do this at the scale that we're trying to do. We're trying to redesign everything all at once. And I think that's a message out to people who may either be thinking about joining the NHS in clinical or other roles, or indeed people who want to come and join us from other organisations, that this is a really exciting time to be in this organisation. And I think part of our recruitment strategy, part of our training strategy needs to come and join us, come and help us design this system that we're starting to put together now. On the other point around quality and safety, you're absolutely right. That needs to be at the core of all of our thinking, not just in the future, but probably more immediately in the here and now, and how we're going to get through the transition period. Because after all, if things were okay, we wouldn't be going through this kind of process to think about how things need to change. And there will be moments for this board, either through the Quality and Safety Committee that you chair, or indeed as a board, that we're going to have to face some difficult moments about how we keep services going, because we know the nature of the fragility every day of what we're dealing with, and it's a lot of these guys over here who are making those decisions. So this isn't going to be an easy transition. If we could make it happen more quickly, then I think we would. But actually, we do have to have some really honest conversations between now and whatever future model we land, about keeping the quality and safety of what we do absolutely at the heart of everything.
Thank you.
Thank you. I have a couple of questions, one of which follows on from what Jill said. And I suppose I'm looking for assurance that I will actually see, or the board will actually see, real pace and momentum around refocusing, as is laid out in Recommendation 1, that there will be some evidence, not just around what's stated there about short-term contracts and resolving those, but actually going much further, so seeking some assurance on that. I also have a specific question relating to the workforce, and again, it's assurance that in everything that Lisa said, we are including the primary care workforce, who we don't employ, other than when we're managing practices, but the whole recruitment issue of those who work in primary care, not just the GPs, but GPs particularly, that we can retain those who are in training and that they are a key feature of that. And then I'd like some assurance that the role of carers is actually feeding through all of this. And although it's been mentioned in ORS, and the feedback, and we know the number of carers, well, we don't know in total the number of carers we have, but we know it's huge, that how they are engaged in this process, so we truly reflect their views.
Perhaps if I start, other people might want to come in, but I suppose look, the first part of your question was about pace around the primary and community care model. And actually, that's the bit that we have to absolutely get on with now, and it's within our grasp to get on with that now. Actually, designing a new hospital will take time, and actually the new hospital won't function as we want it to if we don't get the community and primary care model working right. So we have to absolutely get on with it now. I would say that in the last 3 to 5 years, we have seen the shape of primary and community care already changing. We've seen a much more multi-professional workforce in our GP surgeries. We've got GPs here today who do have a multi-professional workforce in their surgery. And not just that, we've got community connectors, lifestyle advisors, people connecting people to ways to support them to maintain their own health and well-being. So it's not just the sort of traditional sort of primary care sort of care approach. Also, we are already investing in interventions that will support people to maintain their own health and well-being. The issue is that we need to scale it up so that all of our population has the advantage of that. The other bit that a number of people mentioned is the confidence that the community services can support people to stay at home in crisis in quite a number of circumstances throughout the 24-hour period. At the moment, actually the default is just to A&E. And that's why we end up with the issues in our A&Es with people actually who, if we had other services available, wouldn't need to go to our A&E. So there's, and I suppose another area of focus will be digital and technology. So there'll be a range of things that we can get on with in our grasp now. We will seek extra investment in this area because, frankly, there will be some double running to when we get to our completely new model. There'll be a period of time where we'll be double running services. On just a small thing on the workforce future workforce. Again, I think we're already making some steps on that. So we already have got medical students training in rural primary care in our area, connecting with our medical schools. So I suppose those sort of things, they're the start of it, but we're showing that we can do that, and we're going to learn from those pilots. But of course, it's not just the doctors. We need the whole multi-professional workforce. And in terms of carers, I think when we look at our localities, I'm sure somebody else wants to come in, but last thing on carers. Can I say one last small thing? Yeah, sorry. I was trying to answer all of them. Apologies, Chair. So one small thing on carers, just on the localities. We have 7 localities, and within each locality, the carers will be as important as the doctors in what they provide to people, because what matters to people isn't always really what a doctor does for them. So.
Short and sharp on carers. One of the recommendations is very clear about integrating health and social care at pace. There is already work going on, but this decisions today will give a mandate to I suppose, accelerate that, to jointly commission different services. Local authority have significant responsibilities for unpaid carers. Over 20% of our population are unpaid carers, and a significant number more than that responded through ORS, because the doubling of over 75s means a doubling of the numbers of unpaid carers in almost, by default. So we have to have that as a fundamental element of everything we do. So we can only do that well by integrating with health and social care. So that is on track, but this decisions today will allow us to accelerate that at more pace.
You and the same to board members, short, sharp questions, and I'm going to Kerry. No, I'm going to Adam, then Kerry. Sorry.
Thank you, Chair. I just want to make a point that the staff are going to be key in the delivery of this transformation, and we know the evidence says that if staff are treated with compassion and engaged and empowered, then care will inevitably get better and become safer. So given kind of the ORS reports where there isn't a consensus in terms of how staff feel, this may lead to a risk that staff become slightly disengaged and disempowered in the short-term future. So I think it's key that we empower staff to be able to change services that engaged with the public to change your services. I think that's a key element that we've got to do in the next 6 months, year, and that delivery at pace that is shaped in terms of this is forming part of the transforming clinical services will help to build that trust back within the system of some staff that might feel disengaged. And the other point then is around the future-proofing of this transformation. The healthcare of today might not be the healthcare of today in 10 years' time. So by building in that ability within staff, does that future-proof this strategy that staff can be much more flexible in delivering those different healthcare needs in 10, 15, 20 years' time?
Thank you, Adam. Really good points, and we'll address those through the implementation if we ever get to a position, because future-proofing in particular is one that we don't find ourselves in this position long after my day, and many of us around these 4 walls. Kerry.
Thank you. We heard from the gentleman from the Independent Consultation Service that the board is required to consider all the evidence available. I just want to commend the work that went on over the summer with the clinicians that looked at all the evidence available. That was from the consultation and all the feedback. So they were looking at what could work clinically, what could be safe, and what would produce high quality services, and what is sustainable. We've heard from the senior clinicians here today, but there were a wide range of clinicians involved in that piece of work, and it was well represented by all professional groups. The other thing I want to say is that, yes, with change there's risks, and that's been called out. I think given the fact that our clinicians, our senior clinicians and senior managers have worked really hard and relentlessly trying to hold fragile services and medical rotas and keep services safe over the last few years, I think we can have every confidence that that will continue to happen during a time of change. The last thing I want to say really is about the workforce, and that a lot of people have said about the workforce. And I was it was great to hear what the Director of HR said in terms of the plans for the workforce. We need to support the workforce through the times of change. Clinicians and all staff can feel isolated. It can breed uncertainty. Additionally to that, it's good that we've got plans in terms of advanced practitioners, assistant practitioners, and growing our own. But we need to think more radically about what we might need in 10 years' time, which we can't even conceive of now. We can't even think of that now. And it might be that we need certain roles which will not just span services, but span professional registration groups, so that service users can actually have a practitioner that can serve all of their needs or a range of their needs, not multiple practitioners that they have to see for multiple appointments. So that needs planning, but that needs planning now as well. Thank you.
Thanks, Kerry. That's really helpful from the Health Professionals Forum perspective. So thanks very much for those comments. I've then got Mike and Anna. Mike, did your hand go up? No, sorry, straight to Anna.
Thank you, Chair. Two short, sharp questions. We want our services to be safe and sustainable and accessible and kind. Are those four things wholly compatible, or are there some inevitable trade-offs? One question. The second is relating to outcomes. Implicit within the proposals is suggestion that clinical outcomes actually get better for patients. But Steve has reminded us that this is actually a really big stretch in terms of the scale of innovation that we are contemplating here. So what kind of system of evaluation do you have in mind to check back against that hypothesis? And what opportunity is there for patients and communities to get involved in that evaluation?
You get us every time, Anna.
You're looking at me. Right. So I think that's a really good question. And it's something that we considered when we discussed this, because actually that's quite a high bar to have safe, sustainable, accessible and kind services. And actually what some people will say is safe, someone else will have a slightly different view. And that's even more so when you look at accessibility, sustainability and kindness. So I suppose those words have been really useful when we've had our discussions with the public, because actually it has engaged people in some pretty earthy conversations about what really matters to them and the kind of experiences that they've had. But actually relating it to your second point, what they don't do, there isn't an perfect accessibility-ometer or a safety-ometer or a risk-ometer, particularly when we're looking at a whole system change. So I think those words are really important to us, and I think will continue to be important to us. But then your second question then becomes really important in terms of outcomes. We do measure a range of indicators across our services around quality and safety. I think what we will find, and we know, is that all healthcare services across the whole world struggle with a perfect suite of outcome measures. What we are doing at the moment, working with Swansea University, ABMU and Welsh Government, is we're setting up a value-based healthcare programme which looks at developing suites of outcomes with international which we can internationally benchmark, and comparing them also to our resource usage. We're at quite an early stage of that, but I think that will be really useful and hold us in good stead when we go through the implementation stages.
Thank you, Chair. I just wanted to add to what Phil's just said around outcomes and indicators. I think that an interesting point that Anna was making was around community involvement in those. And actually, we can measure, and we can measure that quantitative data in terms of our outcomes and indicators. But
really, the other side is just as important, and that is that qualitative measure and understanding in response to really learning about what matters to the communities and individuals and families within that. Actually, how can we know that we're making a difference? And I think we need to really work with our local communities about how we develop some of that feedback mechanism and understand their patient stories and their experiences in a much tighter way than we're doing at the moment.
Yeah, I just wanted to come back on the first point, just thinking about this at a slightly higher level. I mean, certainly of those 4 words that we set out, probably the one, and we heard it in the feedback, that maybe gives people most concern is the accessibility word. I think if we'd, and this was deliberate thinking up front, if we'd gone for a process which talked about how we simply reconfigured hospital services, there would have been a trade-off between some of those words. The sum of the total of all this, though, when you bring all the parts of it together, I think we should have some confidence that we can improve on all of those things if we get the right community models in place, so that people don't need to be in places that they currently are going to because that's the only access to service they can get. If we have some really new thinking, innovative thinking, the sort of thing that the ambulance service was saying around how we can support some of our more remote communities, and we can pool our resources where they absolutely have to. I think we can. It's not so much about striking a balance, but we can do better on all 4 of those things because we're not just redesigning one part of it. So whilst it took 2 hours to go through it today, that was a necessary reflection of the fact that this is a whole system approach. And in that context, I think we can achieve all 4 of those.
Thank you. I've got Owen and then Paul, and then I'm going to cut it. Oh, sorry, and Hilary, and then I'm going to cut it so we get to the recommendations. Okay, Owen.
Thank you, Chair. I'll try and be brief. The presentation recognised the variation in provision and significant health inequalities that exist, and that was most starkly obviously illustrated by the 10-year gap in life expectancy across Hywel Dda. I suppose my focus in this question is on how we ensure the most vulnerable and disadvantaged, not just those with protected characteristics, those most likely to be affected by health inequalities are involved in the further development of those proposals. And there's a sub-bit to that question, because obviously very impressed with the whole consultation process and the efforts to engage a wide and varied audience in that and to give people the opportunity to express their views. But the proposals now require ongoing continuous engagement over an extended period, and I suppose there's a risk, in my view, of potential consultation fatigue, and how do we ensure that we continue to engage with those disadvantaged groups?
Sarah?
Diolch, Cadeirydd. Thank you for that question. I really welcome it. We've learned an awful lot, as I said in a response to an earlier question, and we've formed certain equalities groups, not just of the protected characteristics, which are our duty, but wider vulnerable groups. For the first time ever, we've met with people who are homeless. We've met with a lot of very vulnerable individuals, worked much more closely with Pembrokeshire People's First and others. And I think we would like to propose to the board at a future meeting a new way forward of how we continuously engage. I think following this board and the arrival of a strategy in November, I think there's a response from our teams to how are we going to do the continuous engagement with all people and specifically those vulnerable groups. I think that we will be proposing some new ways forward of keeping some of the groups that helped us so much in this process, keeping them going. In terms of fatigue, I think what's really important is out of this we will have a work plan of what do we do first. The first thing is we integrate health and social care. We also look at certain pathways. So for each of those, there'll be different stakeholders who are really passionate about that. So we won't be asking the whole population on everything again. This is the first and last time of that for the next generation. What we will be doing is asking, through our membership, we have 1,000 members already, we'll be asking for more. What are you passionate about? Is it cancer? Is it women and children's services? Is it ophthalmology? Come and get involved and design these things with us. So it will be more tailored groups, I think. But we would want to bring that back to our board for how do we do this long-term, consistently, in a continuous way.
And I suppose, Sarah, there's the locality engagement where services are specific to a different locality section, that we would be out trying to work through continuous engagement with the localities at an operational level?
Absolutely. We've got 7 localities. We'll have 4 triumvirates, 4 hospitals to work with. We've got different projects going on for improvement, but also we have agreed with the local authorities that actually we can use our engagement mechanisms to jointly engage, because if we're going to have an integrated structure, we don't have 2 ways of doing it. So we will be becoming more seamless in the way we do things at a locality level and on designing specific pathways.
Thank you, Chair. I just want to come back on one particular point. When we seek to target and speak to those experiencing health inequalities, quite a lot of those individuals don't actually label themselves as disadvantaged. And so therefore, actually, we've got to be really smart in the way that we engage with lots and lots of different people from all different walks of life, so we get that richness without having to label people into certain categories. And that's really important.
Thank you. Paul. Sorry, I forgot your name for a minute.
Thanks. Yes, obviously on the assumption that the recommendations that are put forward today are approved by the board, some assurance as to when we are likely to see some more financial modelling as to what the implications from a cost point of view will be for the implementation of the recommendations, because clearly one of the parameters for this is to ensure that the services are sustainable from a financial perspective as well.
Thanks, Paul. Hugh?
Thank you, Chair. Yes, clearly, excuse me, clearly there will be a strategy coming back to the board in November, and as part of that there will be a first cut assessment of certainly the financial quantum that we're talking about, but clearly that will still be at a high level, and it will take time to work through the detailed modelling of this, not just in terms of the ongoing revenue consequences from any decision that gets taken, but also the capital cost and how that can be funded. So that will take time and be brought forward as part of any business case.
Thanks, Hugh. Hilary.
Thank you, Chair. Well, I think Paul took my question, so I'll make something else up. Just maybe some feedback from the recent stakeholder reference group, where there was general consensus to move forward with the change, acknowledging that there was a need for change, but also acknowledging the diverse views and different views of various communities and how difficult that is to balance out. But we've heard a lot of those conversations around that today. But I suppose one of the asks was that you create a show home, for want of a better expression, to demonstrate how these community models can work. And I was really pleased to hear about all the talk about patient experience and to listen to those patient experiences in changing or managing the process moving forward then. Thank you.
I suppose my only reflection on the show home is that we just don't have the same communities, so it isn't one size that fits all. But I think where there are areas, and particularly that's come through the recommendations of Pembrokeshire, where we know that there are gaps, then that might be a focus that we might want to take through the November responses to whatever we agree on the recommendations and the strategy going forward. So I suppose that's a nice segue into the recommendations. But before I go there, is there anything anybody's got burning to say that hasn't been said by anybody else, that they're going to go out of here and say, damn, I wish I'd said that? Owen.
Thank you very much. Flashing. Oh, there we are. Thank you very much. We've said a lot about enhanced community care and health and social care joining together as the linchpin of the start of this process. My worry is that you run in financial deficit perpetually. Historically, any new innovation has meant cutting finance from another part of the organisation. I do not think that this process can start if that continues, because this will need extra revenue to pump prime in order to enhance community services in order for the secondary care services to manage to be developed. And my great worry is that finance will stop you enhancing your community services in the future.
That's a good question, Owen, actually. I'm going to give it to the boss.
Yeah, thanks, Owen. Thought we'd have the final question, then we get that come through. I think actually you've put your finger right on a very key issue for us in all of these plans, which is how do we invest in those things that we know are going to help us with a much more balanced system when we are spending all the money and more than we've got in the current system. There's no easy answer to that. I mean, I think what we're seeing today is a real commitment that we have to try. We have to get on with that stuff. And there are some opportunities out there to at least start to make some progress. I think we'll see more in the development of the draft strategy for November, but our joint commitment with the 3 local authorities around securing funding from the Transformation Fund nationally, we see as a key lever to start to enable some of that change to happen, as well as, of course, the strong desire that we're having now from across the whole of the Hywel Dda patch to integrate services means that the pool of resources may be bigger and can be used in different ways. So I've got some optimism that we can start to make progress, but actually it is going to be probably one of our biggest challenges to make good progress on that in the short term, and we're going to need to think very innovatively about how we do that in our current situation. I'm looking forward to working with you and generally primary care and our community services and indeed social services to see how we can unlock some of those opportunities.
And no matter what else we're doing, in terms of getting the plan and the actions, we will need to talk to Welsh Government about transitional funding. Because I think that's a given where we are, even with Welsh Government's commitment in terms of the 27 million, our fixed deficit for the end of the year, and I'm just flagging it up in case they're listening today, that we will be coming back with a transitional plan. But when we've nailed some of our financial challenges, and I think, you know, it's not going with a begging bowl saying we can't do this. There are some of it we can do for ourselves, but there will be double running, as you rightly say, and transitional funding that will be required, almost a brokerage, to get us to the inevitability of a sustainable West Wales, Mid and West Wales health system. So it was a good question, and I hope somebody trawl back over this and pick up that we will be coming, but with the evidence as opposed to, look, you know, we've got a begging bowl, we need it filling, because we haven't. We've got more than that now. Subject to recommendations, of course. So going into the recommendations, the first thing I think, and we haven't got a formal position on the CHC's proposals and their views. So I need to ask us, do we formally recognise the CHC's commentary, their observations and their positions before we go into the recommendations that have been put forward by our clinical teams? So that's the first thing. As a board, do we agree with the CHC recommendations on support? Yes? So we can formally adopt those then, which will help us, I think, Sam and John, in terms of the measurement of how we then support the rest of the recommendations, because you make some really strong points in terms of all of our recommendations that we can then go back to for the November strategy when we accept, if we are going to accept the final recommendation. Does that make sense to everybody? Yeah. Okay, so I'm going to recommendation 1. Alison, do you think we can put them up? Oh, thank you. I haven't got eyes in the back of my head, and I didn't turn my neck round, so apologies for that. So that will save me reading them out, really. So is there anybody that's got any dissent or query around recommendation 1? Are you happy to accept? Yes? Sarah?
I would just wonder if we could strengthen, we've put it based on an integrated social model for health and well-being, but I think it also should in there saying, and working with our local authority partners to integrate health and social care.
Yeah. Everybody happy with that? Yeah. Alison?
Could I suggest that it could be even further strengthened about working with the wider partners as well? Because I think from a prevention perspective, it's the whole education, starting from a young age, so I think we could actually strengthen it even further. I know that's a key point, but I think we could go further than that.
John? I don't want to redesign now. We either agree or we don't.
Can I make a general point with regards to this particular recommendation and many of the others, in light of the point that I made earlier? Can we be more explicit in terms of safety within the recommendations that we're making, please?
Yes, I think that's a really good point. So, with those three, we won't rewrite these recommendations now. We will look to the team to encompass what we really need to do is to nail whether we're accepting the recommendations as a driver for the strategy that comes through in November. So everybody's happy with recommendation 1? Yes? Recommendation 2 then is the development of a plan for community hospitals, working with local communities. But there's one thing I want to pull out here, is that within our consultation, we were saying we were almost automatically going to be closing those beds. So we can now accept that we're not closing those beds explicitly. We will be working with the communities on redesigning at locality levels those particular community outlets that we identified through the consultation. And I'm looking directly at Phil.
Yes.
Okay, so we've got a bit of work to do with our communities then. So we're accepting that recommendation 2. Yes? Recommendation 3, that we discount proposal C. I didn't hear anything this morning that would lead me to suggest that we wouldn't agree with that recommendation. Am I right? Recommendation 4 is a modification of the remaining proposals to deliver hospital services, and the list is up there. But I am going to go through it because it is a sensitive area, and I think it is an emotional area, not only for the public, but also for the members of staff who actually designed these proposals. So we are supporting a new urgent and planned care hospital in the south of the Health Board area. Yes? Please say yes or no. Yes. An acute hospital service is retained and developed in Bronglais, which looks towards the Mid Wales region. Yes. Acute medicine is retained on Prince Philip. Yes. And that's given that they've already reinvented themselves and redesigned their front door. So there is an abundant evidence of new models that are coming out of Prince Philip at the minute. So we're content with that one. Yes. And then repurposing Glangwili and Withybush does not mean closing Glangwili and Withybush. Dr. Clare, does it?
No.
Which will offer a range of service to support the social model for health and well-being designed with the people of Carmarthenshire and Pembrokeshire. And we're accepting that? Yes? Okay, and then there's the additionalities, which I'm accepting, that given that we've gone to the recommendation, we're also accepting the additionalities. And in this case, it is the focus with ABMU and aligning our clinical strategies and being able to model pathways, particularly for tertiary services, as well as the future for medicine et al. Yes? Phil?
And I think probably it is worth saying, and the work that Julie pointed out around maintaining consultant-led obstetrics, neonates and acute paediatrics within the health board, and also the connection, integrating the work on mental health from the previous consultation with this consultation, and making sure that we really do, as you said, provide excellent care for the population of Mid Wales through Bronglais and our other services.
Yeah, and I'm glad you drew that out, because otherwise we'd be in danger of glossing over them, particularly obstetrics and midwifery. Recommendation 5, And again, this one is around, and it will attract a lot of discussion, and actually it's almost an agenda item on its own for the future, which is around the location options and the progression to a single site for urgent care and planned, and working with local people, considering the impact and opportunities and developing an approach to manage emergency conditions with that, which are time sensitive. Are we agreed to the recommendation? Yes. Mindful that nothing will change until we've got some substantial infrastructure, and even within the fragile services, everything will go out to consultation. We're not suggesting that we will be cutting any corners in terms of developing the service models, even given that we bring back fragile services as and when we get really worried about them. Yeah. Recommendation 6. We're requested to approve the development of a plan to redesign the 2 existing sites, the remaining sites then, and the new urgent and planned care hospital, working with local authorities, and I think we've already picked that up in the first one. Yes? Recommendation 7 is to approve the development of a detailed plan which addresses the significant concerns, and this is really about the continuous engagement, and we would look to see that coming back. It's featured very clearly in the CHC response, but also in our own response and the work of ORS. So we're agreeing recommendation 7.
In terms of regional transport and strategic transport plan, I don't think it would be a bad thing if the board was to start lobbying Welsh Government to get really significant infrastructure improvements to the A40, perhaps dualling it, for example.
Yeah. Yeah, please.
Yeah, just to say on that, Simon, I think that this will be about working with Welsh Government, but actually also local authority colleagues about what we can do across the whole patch on infrastructure. And I think this is a signal that we want to do some significant amount of work on that to see what the opportunities are. Clearly, we'll need to make our case very clearly to people like Welsh Government.
Recommendation 8 is the... oh, sorry, go on.
Well, if I may, just on 7, I just want to make sure we do pull out that what we were told about WAST and also about EMERTS, that's not just about transport, that they are critical to the development of the new pathways and the service model. Okay.
Yeah. That's it. Who? Phil?
Because Judith wanted to draw it out. I think the point, the issue with the two emergency transport services that are currently 12-hour services, which is our CHANT service for neonatal emergency transport and EMERTS, which is for adult emergency transport services, is that they're both 12-hour services at the moment. Clearly that's a national service, but we need to add a very strong voice, I think, for our population, that this needs to be moved to a 24-hour service, so that which will help us deliver this model and offer us lots of opportunities. But also, of course, this isn't just about emergency transport. There's also the challenges in here about non-emergency transport, and road infrastructure, and also rail and bus infrastructure will be important.
Thank you. And there's a lot in that we will need to nail before we can do any of this. So there's a lot outside of our control that we've got to, as Simon rightly said, start to really up the ante in the lobbying and the discussions. Recommendation 8 is the digital. Are we all agreed? Again, there's a lot here. Mike, sorry.
Thank you, Chair. I decided to hold my previous question to this point. Of all the recommendations, this is the one that concerns me, because the way it's written currently, it implies that Hywel Dda Health Board can deliver this on its own, and we can't. And probably other members who have been... It's a laudable recommendation, but other members have probably been saying this for 10 years. So I just want to make the point that the recommendation as written isn't realistic, so we definitely need others with us on this one, whilst it's laudable.
Karen?
Yeah, we are mindful that we all work within an All Wales digital planning infrastructure, and Mike is right to call that out, and we will need to put that in with it, that we'll work with All Wales basis, with our regional partners, at a locality basis, and of course with our partners.
But and some of this, I mean, in terms of the community systems, we are developing those. We just haven't got them through yet, have we?
There is an All Wales model for community. Yeah. It's clear to say at the moment that it is going through quite a few challenges in terms of making sure it delivers all the functionality that's needed out in community. But that is an All Wales and all local authority, NHS and local authority positions. So we've got a lot of minds to work through those challenges together.
Okay. So recognising what you've said, but we've still got to keep with the recommendation. Because we've still, digital is going to be the platform that's going to help us to deliver all of this. So we won't slack off the pace to be able to bring it in.
Sorry, just to provide assurance, A Healthier Wales already signals that direction of travel is there in both at Welsh Government and within organisations in the NHS in Wales and the local authorities. So I think the board should be assured by that because it's a policy direction.
Thank you very much. Recommendation 9 is around the workforce redesign and the transformation plan. And you can see the list of recommendations there. Happy to agree. Delyth.
Odi, mae'n gweithio. Fi'n mynd i siarad yn Gymraeg os ydy hwn yn iawn, a fi'n credu bod, and I will do it bilingually, because I think this is an important issue. The Welsh language is the language of nearly 60% of our patients and service users in Ceredigion, and 51, nearly 52% in Sir in Carmarthenshire. So I would like the Welsh language provision to be reflected in this, and also thinking about our existing staff and workforce, giving opportunities for our existing staff to train and work and live in Welsh. Our patients deserve that. When we look at patient experience, often there is an issue for patients, especially dementia or speech and language therapy, where patients do need to speak in the language of their choice. So I know I flicked on to English or Saesneg, and I think it is an important issue. Sir Ceredigion and even Pembrokeshire.
Can we ensure that we reflect that in the recommendation? Because it's a really good point to work and provide care where we can in Welsh. Recommendation 10 is continuously engaging and supporting the co-production between staff and local people. And that will feature in November, given that we will be looking at innovative ways to engage. And then recommendation 11 is around the approval of all of the recommendations into a health strategy for consideration on the 29th of November. Everybody happy? Phil, I don't want to put you on the spot, but I don't want to raise expectations. So what do you think we will be seeing in November?
Thanks, Chair. I mean, I think recognising the fact it is currently September, late September, and November is only 2 months away, there is only a short period of time to put together that work. And I suppose it's rather like Hugh's comment about the finances. We will need to develop increasing levels of detail on our future health services, which will go on for many years. However, what we want to bring to board is a draft health strategy that does bring together our health and wellbeing work that our Director of Public Health leads and our design for our services in line with the recommendations that have come today. So we will get everybody, but of course we'll be constrained by the amount of detail that we can develop in a 2-month period.
When we come back, we're not coming back expecting more than we can deliver. And, you know, what we've agreed through the recommendations are a clinical strategy, one of which we've never had before. And for that, I thank everybody. I thank the board. I thank all of the presenters and all of the members of the public who've engaged. But I do recognise that not everybody will be happy today. And we just have to continuously work with all of our populations to ensure some sustainability going forward. So thank you very much, and I hope your bladders have all lasted out.